Ladies and gentlemen, esteemed guests, delegates, and dear students, welcome to the much awaited OTICON 2024, the 61st Annual National Conference of All India Occupational Therapists Association. The anticipation leading up to this event has been palpable as professionals from across the nation eagerly look forward to exchanging ideas, discovering the latest advancements, and creating new connections. As we embark on this journey over the next few days, we encourage you to fully immerse yourself in the wealth of knowledge and experiences that will be shared here. Once again, a warm welcome to everyone. To begin the pre-conference continuing occupational therapy education program, I would like to invite Dr. Chandrababu C., Executive Director of National Institute of Physical Medicine and Rehabilitation, onto the dais. Next, I invite Dr. Nawaz KM, Chairman and Managing Trustee of KMCT Group of Institutions. Next, I invite Dr. Anil K. Srivastava, President of All India Occupational Therapists Association and Executive Chairman of the Academic Council of Occupational Therapy. Next, I invite Dr. Jyotika Bijlani, Dean of Academic Council of Occupational Therapy. I now invite Dr. Prem Raj Isaac Chandran, Director of Adult Rehabilitation, Occupational Therapy, Hamad Medical Corporation. I invite Dr. Joseph Sunny, Honorary Secretary of All India Occupational Therapists Association and the Organizing Secretary of OTICON 2024. I would also like to invite our additional resource persons, Mr. Nekram Upadhyay, Head of the Department of Assistive Technology and at Indian Spinal Injury Center, Mr. Deepak Joshi, Associate Professor at Center for Biomedical Engineering, IIT Delhi, and Joint Faculty with All India Institute of Medical Sciences, New Delhi. And Mr. Salah Adarbe, Occupational Therapy Specialist and Assistive Technology Coordinator at Hamad Medical Corporation. Unfortunately, due to unforeseen circumstances, they won't be able to join us in person. Nevertheless, they will be joining us virtually. Let us begin with a moment of reflection and unity. I now invite Ms. Fadia KM and Ms. Najia to grace this occasion with a prayer song.
ആനന്ദയാലുവായി ദാക്ഷിണ്യശാലിയായി വാഴുന്നോരീശ്വരൻ തിരുനാമത്തിൽ നിഖില ലോകങ്ങൾക്കുമേൽ രക്ഷകനാകും അഖിലേശ്വരനല്ലയോ സകല സ്തുതിയും അഖിലേശ്വരനല്ലയോ സകല സ്തുതിയും പരമകാരുണ്യവാൻ കരുണാനിധിയേ വിധി പറയും ദിവസത്തിൽ ഏകാധിപനെ നിയതമാരാധിപ്പൂ ഞങ്ങളങ്ങൈ മാത്രം സതതം സഹായമർപ്പിപ്പതും തിരുമുന്നിൽ നയിക്കണം ഞങ്ങളെ നേരായ മാർഗത്തിൽ നിന്നനുഗ്രഹപാത്രമാ മാർഗഭ്രഷ്ടർ തൻ വഴിയിലുമല്ല. ആരന്തയാലുവായി ദാക്ഷിണ്യശാലിയായി വാഴുന്നോരീശ്വരൻ തിരുനാമത്തിൽ നിഖില ലോകങ്ങൾക്കുമേകരക്ഷകനാകും അഖിലേശ്വരനല്ലയോ സകല സ്തുതിയും. അഖിലേശ്വരനല്ലയോ സകല സ്തുതിയും. അഖിലേശ്വരനല്ലയോ സകല സ്തുതിയും.
To commence the pre-conference COT, Continuing Occupational Therapy Education, I invite Dr. Kamal Arya, Executive Committee Member of the Academic Council of Occupational Therapy.
Hello, good morning all. On the behalf of Academic Council of Occupational Therapy, that is ACOT, I, Dr. Kamal Arya, Executive Member of ACOT, welcomes you all. May I request our EC members of ACOT to kindly felicitate our guests. I also request Dr. Sunny Joseph to kindly hand over a memento to our guest. Sunny. May I again request our EC members to felicitate our other guest, Dr. Chandrababu. May I also now request our EC members to felicitate our President of All India Occupational Therapists Association and Executive Chairperson, ACOT. May I now request to felicitate Dean ACOT. I also request to felicitate our Organizing Secretary of OTICON 24. May I now request to felicitate our Speaker of the Day, Dr. Premraj Isaac Chandra. I also request Dr. Sunny to kindly hand over a memento to Dr. Isaac. We also welcome our other speakers who have connected online, Dr. Nekram Upadhyay, Dr. Deepak Joshi, and Dr. Sala Adarbe. May I now request our Dr. Anil Srivastav, sir, President All India Occupational Therapist and Executive Chairman of Academic Council of Occupational Therapy, to deliver his presidential address.
Very good morning to you all. It's really my pleasure to welcome you all today on the occasion of OTICON 2024, beginning today. And this is a routine that before every conference, we organize the pre-conference continuing OT education program under the domain of our Academic Council of Occupational Therapy. So we today in the morning we are assembled here for the pre-conference continuing OT education program. Hope you will all will academically enrich your knowledge base with the speakers and the resource persons speaking today. On behalf of All India Occupational Therapists Association and Academic Council of Occupational Therapy, a warm welcome to you all delegates, guests, and my dear students. I gratefully acknowledge the presence of the national and international guests and our Indian OTs working in India and other countries. Very special welcome to our resource persons and panelists of today's pre-conference continuing OT education program, Mr. Nikam Upadhyay, Mr. Prem Raj Chandran, Dr. Deepak Joshi, on this occasion today. Congratulations to Dean Accord, Dr. Jyotka Bizlani, and Accord team for tirelessly working during this tenure and organizing continuing OT education programs and short duration courses and workshops by AIOTA itself in collaboration with the national and international institutions and organizations at regular intervals on different areas of OT practice. AIOTA academic events are now much awaited events by members and OT professionals in India and overseas. AIOTA is now fully equipped to conduct these courses by online mode too from AIOTA headquarters, and it resulted into participation of many overseas OTs and including the expert faculty from other countries. The academic activities of AIOTA has increased manifold with overwhelming response from OTs in India and overseas in past few years. The topic of today's continuing OT education program is artificial intelligence and assistive technology. The invited faculties and panelists are having deep knowledge, expertise, and competency in the subject, and hence they are here to interact with you to discuss OT intervention in artificial intelligence and assistive technology. World Health Organization informs that about 15% of the world population has some form of disability. The valued inclusion of assistive technology in occupational therapy intervention contributes directly to the overcoming of difficulties encountered by the people with disabilities in their daily life. It allows them to receive education, work, and society in a worthy manner. Artificial intelligence has revolutionized numerous industries from healthcare to finance, transportation to the entertainment. However, one aspect that is often overlooked is its potential to enhance accessibility for individuals and disabilities. Artificial intelligence accessibility is a powerful tool that can level the playing field and empower people with disability to lead more independent and fulfilling lives. Assistive technology has made great advances in its integration with artificial intelligence devices. Such devices processes and analyzes the large amount of data generated by internet devices and applies artificial intelligence models, specifically machine learning, to discover patterns for generating insights and assisting in decision making. Pre-conference continuing OT education program has been a regular feature of AIOTA National Conference under the ambit of Academic Council of Occupational Therapy. I'm confident that the delegates and young generation OTs would welcome the academic deliberations on a newer topic. We would appreciate to receive your feedback on this program and also suggestions for our future endeavors. So thank you very much.
Thank you, sir, for your inspiring words. May I now request our EC members to kindly felicitate our chief guest of the program, Honorable Member of Parliament, Shri Haibi Aydin ji. I also request our President, sir, to kindly honor the guest. I also request Dr. Sunny to kindly hand over a memento to our chief guest. Thank you, sir. I now request Dr. Jyotika Bijlani, Dean Academic Council of Occupational Therapy, to introduce about the today's continuing occupational therapy education program. Ma'am.
Thank you, Dr. Kamal, and namaskaram to all of you. Namaskaram to all of you. So respected Honorable Chief Guest, Executive Director Chandrabau, and Chairman Dr. Nawaz. On behalf of Academic Council of Occupational Therapy, I'm extremely happy to welcome all the dignitaries on the dais, Dr. Srivastava, Dr. San Joseph, and Dr. Chandra Isak, Prem Raj Chandra Isak, and other dignitaries of the ground, I'm to say, sitting down, and my colleagues and very, very dear students. I welcome you all today for pre-conference continuing occupational therapy program. So I would take this opportunity to extend my big thanks to all the guests and chief guests for accepting our invitation in this inaugural function held as part of OTICON 2024. As a Dean, Academic Council of OT, I wholeheartedly welcome again to all the delegates, guests who are attending today's program. ACOT is committed to infusing academic excellence in the clinical practice of occupational therapists in India. So to achieve this, Academic Council team, with fullest cooperation of all the IOTA executives, has been working hard to execute continuing OT programs. And also we hold the fellowship programs in different areas of OT practice. ACOT has been leading and organizing energetic OT programs on various contemporary topics, and this momentum would be continued and accelerated in coming years to spread the knowledge. It is, as it is rightly said, we are drowning in the information, but starved for the knowledge. That is John Nesbitt. Academic Council of Occupational Therapy, therefore, organizes pre-conference COTE every year during the conference time. So which undoubtedly is very important to create opportunities to improve your knowledge on many various contemporary subjects. On this, I would like to quote again that knowledge is proud that he has learned so much. Wisdom is humble, that he knows no more. That is William Cowper. So this year, the subject of the discussion is COTE, that is artificial intelligence and assistive technology, its application in occupational therapy. Artificial intelligence, which was once upon a time a buzzword, has become an integral part of our lives. AI, that is artificial intelligence, is shaping the future of technology and revolutionizing our lifestyle. AI is an advanced and modern tool, and when used in conjunction with clinical practice, would enhance the benefit of occupational therapy significantly. Therefore, it is extremely important to include AI into assistive technology to meet the challenges and improve the occupational performance of the specific clients. So we need to get our act together, enhance our knowledge of AI too. This year, we have the topic which I have already mentioned. And so there will be 4 speakers, Dr. Nekram Upadhyay, Dr. Deepak Joshi, both from Delhi, Dr. Prem Raj Isaac, and Dr. Salah Adarban, both of occupational therapists from Qatar. They will be sharing their experiences on this subject, and then this will be followed by the panel discussion that is on bridging the barriers, connecting the missing link between human and technology. This would be a great opportunity to reach out to many students and therapists to facilitate the learning on advanced methods of assistive technologies in OT. At this stage, I would like one more quote to make the point that artificial intelligence is not a substitute for human intelligence. It is a tool to amplify human creativity and integrity. So all the speakers of today's have been the main proponents of their respective fields for the several years and have great understanding
all across the country to be a part of the 61st Annual National Conference of the All India Occupational Therapist Association. It's a great honor and privilege for me to be a part of this very auspicious gathering. Everybody inside the hall are subject experts and professionals on this particular matter apart from me. So I don't think I'm the right person to be addressing a gathering like this, because there are a numerous number of classes, deliberations, and many subject experts and people from the arena would be speaking on. My job as a member of the parliament or a people's representative is always to make sure that when a law is made in the parliament for the country, I should make sure that your voice is also heard. When the Allied Medical Council Bill was passed in the parliament, I understand that even now in the state of Kerala, or for that matter, many other states, haven't passed the particular bill, which would definitely help you and give you more power to your fraternity. And I believe that every state should be taking this particular issue forward. And as a member of the parliament and people's representative, I would make sure that I would put more pressure. I would make that your voices are heard in many different states, including Kerala. I always believed that I was a member of the Legislative Assembly twice, and now I'm a member of the Parliament. So I was a part of making the laws for the state, and now I'm a part of making the laws for the country. So whenever we speak about development, whenever we say about growth, there is a notion or there is a misconception that growth is based or development is based on the number of bridges and roads and infrastructure you build upon. But I have a totally different view on this particular matter. That is how I started a super specialty medical camp during my early days in 2013. This was an inclusion of all the private hospitals and government hospitals to help the Indian underprivileged for their medical ailments. And a lot of CSR was pulled in to have their follow-up treatments as well. So I believe that the happiness they get whenever we see a patient, whenever we see a person who's in distress, and when I try to help them, especially with their medical aids and ailments, that is when I believe that I get, as a member of the people's representative, I get the most happy. I'll be more happy when I try to help them. So inclusive growth is something which is the need of the hour. Whenever we make any kind of developments, I believe that all the people in our society should be a part of those growth and development. And that is when you always have an opportunity to make sure that their voices are heard. That is the arena which you are working upon. The fraternity you are based upon is the occupational therapy, which helps a lot of people to come back to their lives, to do their jobs. There are a lot of people in our society who have a lot of different issues, not just age, but even very, very small children who are autistic, who've been a part of major accidents, who have had stroke, who have had multiple issues, to come back to their day-to-day lives. And helping such a person is the most creative job you can do. And that is something which is God-gifted to get somebody back on foot. And I would like to congratulate all of you for doing that creative part of your life, not just doing a regular job, but every day for you is a new challenge. And I believe that that is something like the surgeons and doctors and the nurses do. This is something which is very important. So I always think that inclusivity is something which we should always have. And when we do a bill, when we make a bill, when we make laws for the country, when we make laws for the state, it is always important to make sure that all the people in our society, all the voices in our society are heard. And that is when, as I mentioned, we should also include people when we say about development. I believe that in many countries, we say that happiness index ratio is something which decides the growth factor of a country. If a person is happy, if a person who's disabled, differently abled, autistic, many issues they face. Even in a state like Kerala, when we say that we are 100% literate state, we say that our formal system of education is the best in the country. 200 years back, we started the formal system of education. We say that the highest number of students getting enrolled to the higher education sector, according to the national statistics, is from Kerala. We boast about all these things. But we know that our country has passed a law in 2008 called the Right to Education Act. Right to Education Act ensures you that up to the age of 14, you have to get free and compulsory education, which is again the fundamental right. It has been a constitutional amendment and it has been a fundamental right. But when a normal student has an access to free education, a person who is in distress, who is differently abled, who is a special child, again needs to spend money on their education. This is a disparity, or this is something which always amazes me. Why does a normal child get free education? And why does a special child who needs special attention, special care, special teaching, teachers have to pay? So I have a lot of friends and their children who study in special schools, private schools, because government doesn't provide them special schools, or when the aided school teachers are paid by the government, these teachers are not paid by the government. There was a proposal initially for this when Sri Umman Chandi was the Chief Minister of Kerala. But unfortunately, there are many hurdles and barriers to overcome that. So my entire point is the job you're trying to do, the courses you're trying to make, the continuous educational process you're having is something which is very important in our society. In a matured society, in a progressive country, I believe that this should be also a statistics and yardstick of our growth in the country. If our country cannot provide education to these kind of children, if our country cannot make sure that even though we say a lot of things about the improvement of health and progress, even if now we are not able to bring back to their normal lives, as Madam mentioned about artificial intelligence, we have a lot of scope for many such arenas where technology can be integrated to make our lives easy. And I believe that your process of learning would continue, your process of therapy would continue, and these deliberations and conversations would make you more equipped to make sure that every voice of our country, every people in our society is being served justice. And I truly wish all the very best for your deliberations today, for the conference today. And I believe that more productive discussions come up, which can always be helpful for people like us. As I said, whenever we make laws for the country, it is your voice which we are raising in the parliament. So it is always necessary to make sure that you're heard. And whenever we speak in the parliament and when we make amendments in the law, we always make sure to hear you, to make sure that your voices are clearly reflected, because the people sitting inside a hall and discussing stuff might not be exactly able to understand what exactly are they trying to make. Especially the bureaucratic community does not hear to the voices. So we are here to listen to you, to understand you, and to make sure that your voices are also heard in the country. So I wish you all the very best and make sure that you have a very productive day today. And also, please, people who are coming from the other parts of the state and the country. I welcome you to the city of Kochi in the Queen of Arabian Sea. And not just the conference, you can also enjoy our backwaters and have lovely seafood from our city. Thank you. Jai Hind.
Thank you very much, sir. Your great concern, guidance, and uplifting message will definitely provide us a new direction in our professional development. Vidya prashate lokaye, vidya sarvat gaurva, vidya lapte sarvam, vidwan sarvat pujete. Knowledge is extolled by everyone. Knowledge is considered great everywhere. One can attain everything with the help of knowledge. Person is respected everywhere. With this novel thought, I request all the dignitaries on the dais to kindly proceed for the lamp lighting.
शिवकरं शिवात्मानं देव मनोहर महामंत्र
Thank you all. May I now request Dr. Nawaz Kem to kindly deliver his address.
Honorable Member of the Parliament, Sri I.B. Eden, the Chief Guest of the Day, Dr. Kamala Arya, Executive Member, Academic Council of OT, Dr. Anil Srivastava, President, All India Occupational Therapist Association, Dr. Jyotiga Vigilani, Dr. C. Chandrababu, my dear friend Joseph Sani, Doctor, and Dr. Prem, and the occupational therapist, the professionals, the students of occupational therapy who had gathered here for the continuing education program in relation to 61st All India Conference of Occupational Therapists of India. I am staying at Calicut, which is about 200 kilometers from here. I reached here yesterday evening itself to attend this function. I'm a radiologist. I'm the chairman of KMCT Group of Institutions, which is running a lot of educational institutions, including medical college, dental college, and so many other colleges, about 25 institutions. I came here yesterday itself, not to be late for this conference, for the pre-conference workshop, because rehabilitation of human beings in any form is close to my heart. I was here sharply at 9 o'clock. When I was doing my MBBS at Calicut Medical College during my third year, there was a popular textbook for trauma. It was called Adams. In Adams, regarding trauma, it was mentioned how to deal with trauma. The question was whether to immobilize that part or the patient. The answer was we may or may not require immobilization. The second question was whether we have to do surgery or interfere with that patient. The answer was we may or may not have to do surgery on that patient. The third question was what about rehabilitation? And that is one thing. We should start doing rehabilitation at the point of trauma itself. There is no doubt about that. So rehabilitation forms the most important part of the clinical medicine. When I talk about rehabilitation, when I came here, I was shocked to see that the Occupational Therapy Conference is the 61st Occupational Therapy Conference, which is much older than me. I knew about occupational therapy only 15 or 20 years back. And the awareness regarding occupational therapy is very, very low in a fully literate state like Kerala. It is very, very unfortunate. First, we should create awareness about the rehabilitation. Then we have to create awareness about rehabilitation as a teamwork. Teamwork involving the physiatrist, the occupational therapist, the physiotherapist, the speech and hearing therapist, the psychologist, the rehabilitation psychologist, orthotic and prosthetic specialist, and social workers. This is not, unfortunately, this is not happening in many places, especially in Kerala. So we have to have adequate teamwork. We have to do teamwork to make sure that the 15% of the people who are having different forms of a disability, to bring them back as a total person to their work, their occupation, their home, and occupational therapists play a major role in that. When some time back, when I was introduced to occupational therapy, when I talked about occupational therapy, people say that occupational therapy is the physiotherapy of the hand. So we have to spread awareness that it is not the physiotherapy of the hand. It is a science which brings back to the patient, to their occupation, to their surroundings, to do their things on their own. So that kind of awareness should be there. I'm here because I've just started occupational therapy course in my institutions. I have admitted 20 students this year. And in fact, this is the first pure private occupational therapy college in the whole of Kerala. We want to take occupational therapy to a greater heights, and we want to run comprehensive rehabilitation center in northern Kerala. The topic what we have chosen for your continuing education program, that is artificial intelligence and assisted technologies in occupational therapy. Artificial intelligence plays a big role in all rehabilitation sciences, in all medical fields, in all fields of science, including agriculture. But here in occupational therapy, it is not limited to artificial intelligence. It is to all the new things that is happening in the modern world. whether it is 3D printing, whether it is robotics, whether it is Internet of Things, whether it is material sciences. The updation regarding all these sciences plays an important role in occupational therapy. The weight of the material you use in prosthetics or orthotics determines the happiness of the patient who is undergoing your therapy. But there is one apprehension whether the artificial intelligence will take away the job of occupational therapist, a physiotherapist, or even for that matter, doctors. I'm a radiologist, whether radiologist doctor role will be taken away by artificial intelligence. But the final conclusion is the role may not be taken away, but we are sure that people who doesn't know artificial intelligence, their role will be taken away. Then the people who know about artificial intelligence, any profession, they will remain in the profession. With new technologies, we can have, we can provide service to more and more people. At least 1 billion people in the world require your care. So with the technology, you should make that these technologies your slaves and not your masters. And your profession requires a lot of empathy. And no AI technology can take away a professional's job who requires a lot of empathy. With these few words, I wish this continuing education program all success, all bright future for all occupational therapists. And I wish that you serve more and more people with the aid of technologies, what you learn from here. Thank you very much.
Thank you very much, sir, for your kind and inspiring words and taking keen interest in our occupational therapy education and profession. May I now invite Dr. Chandrababu to kindly deliver his address. Sir, please.
Respected Chairman of this August conference, Dr. Anil Srivastava, Dr. Jyotika Jilani, Dr. Kamal Arya, Dr. Nawaz, our other dignitaries on the dais, my dear friends. I am representing a prestigious institution named the National Institute of Physical Medicine and Rehabilitation. As Dr. Nawaz has rightly said, where the rehabilitation must take place in a multidisciplinary setup. You can see what rehabilitation can do for the people of Kerala in my institution, NIPMR. We are the first institution in Kerala, along with the niche, to start occupational therapy course 4 years back. The first batch is going to come out the next year. We have every facility regarding, as you might have read or studied in your courses, but you can see everything live in NIPMR, and I welcome all of you to visit, find some time to visit NIPMR and feel the organization and suggest any modification or improvement. Here, the topic of this here is artificial intelligence and assistive technology. It's a very interesting topic. All people sitting are professionals. I am from an administrative side, working more than 30 years in a rural development department as a joint development commissioner, a block development officer, joint development. After that, I came here. I am learning all this from you people. Actually, our occupational therapist taught me about rehabilitation, and I studied rehabilitation from them. Anyway, I have some few thoughts about a non-professional. If I take it as a few thoughts from the non-professional regarding this. In the era of Elon Musk and AI, do occupational therapy have future? We must think it over. Will AI replace rehab professionals? Everywhere, we must think about it. And you might have this, whenever technology came, or this thought is there, the man-machine conflict is always there. When steam engine came, any computer came, every time people are apprehensive about the future of professions related to that thing. You must have heard the man called John Henry, who is a muscle man working in the railway. He has, when steam engine came, there was a competition between him and the machine. Finally, the man succeeded, but he lost his life. In the computer age, we have the story of Garry Kasparov. He has a competition of playing chess with the Deep Blue, the computer. Several times, the computer and Garry Kasparov where we drew, both of the didn't succeed, but finally the Garry Kasparov surrendered to the computer. That is a real story what happened. But every time this doesn't happen, this doesn't need to happen. We must be very cautious about it. Why people approach rehabilitation? Here there are doctors, professionals here. Why we approach doctors? Every doctor has a protocol. Every professional has a protocol. Why people prefer some professionals than others? Because not only they use technology, they use their mind to give solace to the client. They treat the clients as human beings. When we treat our client as human being, then only we can provide solace, cure to the patient. That is the main thing we must follow. Otherwise, everybody can use technology, everybody can use treatment protocols, but cure won't happen. When we treat our people, our clients as another human being, same as us, then only we can provide service to them in a fruitful manner. With these few words, I conclude my speech and I wish all success for this endeavor. Thank you so much.
Thanks a lot, sir, for your encouraging words and guidance and having vision for development of our occupational therapy profession. May I now request Dr. Zareen Farzandi, Executive Member of the Academic Council of Occupational Therapy, to kindly deliver vote of thanks.
Thank you, Dr. Kamal. Good morning, everyone. It is my privilege to extend my sincere thanks and gratitude on behalf of the Academic Council of Occupational Therapists, the All India OT Association, to our distinguished guest of today. Our chief guest, Honorable Member of Parliament, Shri Hebe Eden, Guest of Honor, Shri C. Chandra Babu, Director of NIPMAR, Guest of Honor, Dr. Nawaz KM, Chairman and Managing Trustee of KMCT Group of Industries, President, All India OT Association and Chairman of the Academic Council of Occupational Therapy, Dr. Anil Shrivastava, Dean of Academic Council of OT, Dr. Jyotika Bijlani, the Organizing Secretary of the 61st National Conference of AIOTA, Dr. Joseph Sunny, and the team of Kerala Occupational Therapists Association. I would also like to extend my thanks and acknowledgement to the resource speakers of Kochi, Dr. Premraj, who is here with us, and the other 3 speakers who will be online, who will not only help us enhance the knowledge of occupational therapists who are present here with their expertise. I would never forget to thank all our delegates, both national and international, our dear students, the media, press, and definitely the scientific committee who has worked endlessly for us. Respected dignitaries, I thank you once again for taking out your precious time and gracing this academic meet. Your presence has definitely made a significant impact and created an amazing positive energy which will drive us to serve society with more zeal and enthusiasm. Thank you once again. I request you, dignitaries, to proceed to inaugurate the free pediatric disability screening and caretaker camp organized by All India OT Association and the Kerala Branch of Occupational Therapy. Thank you once again, and may we have a very productive and a successful conference. Thank you.
A very good morning and a warm welcome to one and everyone who is present in the hall for today's occasion on the occasion of 61st Annual National Conference of AIOTA OTICON 2024. As we all are aware that the driving element for any scientific session is continuing occupational therapy education program. So, to begin with, let us be an enthusiastic learning participant for today's Kochi program, which is on artificial intelligence and assistive technology and its application to our occupational therapy practice. I, Dr. Vijay Batra, Executive Committee Member, Academic Council of Occupational Therapy, feel extremely honored for having been given this opportunity to introduce our eminent speakers for today's Kote program. So to begin with, I would like to call upon our our Dr. Neeraj Mishra, who will highlight on the need of this artificial intelligence in the occupational therapy practice. Dr. Neeraj Mishra, please. Dr. Neeraj Mishra is an occupational therapist with GB Pant Hospital, and he is also a master's in occupational therapy with certified in the artificial intelligence program. Apart from this, he is also a recipient of national and international awards. Dr. Neeraj Mishra, please. He is also our panelist for today's group discussion, the panel discussion for the artificial intelligence and occupational therapy practice. Dr. Neeraj Mishra, please.
Good morning to all respected delegates and members of AIOTA. And thanks to Academic Committee of Occupational Therapy for thinking of doing a program on this topic. So why we thought of doing a program on this topic? What is new about this? We have been hearing the word assistive technology. Almost all of us here are aware of assistive technology. We have been hearing about artificial intelligence, as the previous dignitaries also highlighted, that it has been there for quite a while. But are we actually using it in day-to-day practice? How many of you have heard about Chat GPT? Please raise your hands. Very good. And how many of you have used Chat GPT in your day-to-day practice? Day-to-day clinical practice. The students are very happy because their proposal gets ready like this. But as a clinician, have you used Chat GPT? Again, I'm asking, how many of us have used Chat GPT as a clinician in clinical practice? See, count the number of hands. This exactly is the reason why we thought of taking up this topic. Because although we know what is assistive technology, what is AI, but somehow we are reluctant to use it. And there are also certain challenges which are hindering from that. I'll tell you a global scenario. WHO in 2022 has released a data that as of today, there is a need of 2.5 billion assistive technology products in the world. 2.5 billion. And by 2050, this number is going to become 3.5 billion. And do you know how much is the access to this technology? In low-income countries, it is 3%. So out of the eligible group, only 3% are able to get this assistive technology devices. And in the highest income group, the number goes to 80%. In India, we are already struggling with the problems of lack of accessibility, shortage of specialists, and limited resources. So with these shortages, how assistive technology and artificial intelligence have the potential to revolutionize rehabilitation practices in India? Can we think of something that we can incorporate into our day-to-day practice? You will be listening to the various speakers on this topic, and they will be telling you not only how you can do, but how they have already been doing it. So through different case studies and all. And when we say assistive technology and AI, it is starting from advanced prosthetics to AI-powered personalized therapy. These tools offer innovative solutions to improve quality of care and outcome of the patients. Now, what are the benefits? Apart from all of you know that it improves, maintains performances, but it enhances personalization if you add an AI component to it. What is the meaning of personalization? That it can be customized, tailor-made as per the exact need of the unique client that you are seeing it. The efficiency with which you are working, I will be showing you an example, will increase many folds. You cannot imagine the speed with which you can work. And there could also be a possibility of real-time monitoring, that many times we think we have given a therapy program and it will work, but how to monitor it in day-to-day life? So this can be provided to you through artificial intelligence. Examples, it will be discussed during the various lectures about robot-assisted therapy, virtual reality program, and exoskeleton technology. I won't be telling you the details of this. And as I said, it will enhance mobility and help you to customize the solutions that you want to give to your client, what they want as per their unique needs. One benefit of artificial intelligence is that it allows you to give data-driven insights. Data-driven insight means that what happens that suppose you have been giving a program on 100 of your clients, but you are not able to find out which of them is the best to go ahead with. So then instead of you deciding it, there is a software which will decide and tell you. So eventually it is going to impact on the policy formulation also. And one more question before I go ahead. How many of you make PPT in your day-to-day routine? PowerPoint presentation, I guess all of us are making. So if I tell you to make a 10-slide PPT on types of assistive technology devices, how long will it take? Any idea to make? Anyone? 1 hour? If I tell you to add nice pictures into it, then 1 hour, 30 minutes. And if I tell you to add graphics to it, then how much it will take? Around 2 hours. Am I correct? If you use AI, let's see how much time this will take. Watch this video. So I have put up a AI software and I have asked it to make a presentation on types of assistive technology. I have the option of deciding how many slides I want. I can make 5 slides, 8 slides, 10 slides, 20 slides, 100 slides. So I just select, let's say, 8 slides. Now look at your watch. Your presentation is getting made. Keep counting how much time it will take. This is the outline of your presentation. I will select the background that I want. So I have selected a fancy background for my presentation. I will go and click on generate. So now the AI software will start working and see the result that it will give me. This is my first slide. I am not doing anything. Pictures added, graphics added, contents added. All of which can be customized further as per your needs. So it has taken me 2 minutes to make a 8-slide PPT with all pictures, graphics, and text. So this is the speed with which AI can work. So a work of 2 hours has been reduced to 2 minutes. And what is the future that is going to come? AI integration into all rehabilitation processes. You will get to know through the various speakers how they are using it. And smart sensing system. Smart sensing system is what? There is no one person who is looking you, but the system is watching you. So I'll give you one example of that system. In China, they have already developed a software in which any person standing anywhere in China is picked up by the AI software, and based upon their facial expression and gesture, they are trying to find out what kind of discussion they are indulging into and whether they are all Chinese or they are foreign nationals. So to that extent, it is going to invade into your day-to-day life. And that is where the ethical concerns will also come in. That there is a problem of autonomy and consent. So people might be monitoring you without you actually knowing it. And transparency and accountability is again a question mark. And finally, equity and fairness. So without someone telling you, you might be thrown out of the job because you are not able to cope up. So just to conclude that, there is always a concern that if people will start working so fast, machines will start taking up everything, there will be an increased unemployment. You might be shocked. Just last month, Google has removed around 1,000 employees from its IT section last month itself, all because of AI-driven technology softwares. See, sometimes technology can misfire, like it is misfiring now. And then the human factor comes into play. So what the dignitary was telling, remember, machine should work for you. You should not become the slaves of machine. That is a very important point, because if you will not upgrade your knowledge with time, you will lag behind. And in today's world, if you are not competent with AI technology and how to use in day-to-day life, in the coming years, everything is going to be machinized. And there will be much better softwares which will make your work a lot easier. So I think it is still not being solved. So I'll just conclude here. We have 4 speakers waiting for us. So thank you so much. And then, as ma'am has already said, be attentive for the next 4 lectures. We will be having questions from all of them, and there is a prize for the winners. Thank you.
Dr. Neeraj Mitra, for highlighting on the artificial intelligence and its relevance. Now, without wasting time, I would like to call upon our next speaker, Dr. Premraj Isaac Chandran. He is the Director of Occupational Therapy, Hamad Medical Corporation. He is a PhD scholar. He is a clinician, academician, and a researcher with more than 20 years of experience in the field of occupational therapy. He has held various academic positions, including Assistant Professor in Occupational Therapy at SRM College. He is a founder of Robotic Model of Care at Qatar Rehabilitation Institute for OTs in Neurorehabilitation. He is also a recipient of various national and international awards and has published many research papers in the index journals. So, may I request Dr. Premraj Isaac to hand over the mic. Before he starts, I would like to make a small announcement. All the participants who have any query, any question for the session, they can write down a slip write down on a slip and give it backstage so that we can address to your issue or the concern arising after all the lectures of the Kochi immediately after the session. Thank you. Dr. Isaac, please.
before the slides are checked. Good morning to all of you. Just 1 minute of not this pre-code serious thing. In 1999, I was a student and I was sitting like this in a conference. I really don't know what was going on in the conference. So for people who don't want to listen to all the scientific things, it's okay to be a student. I was also like you. But today I'm standing here because I became serious somewhere in the life at some point of time. So be serious at some point of time so that you can also stand like I'm standing. I don't know Dr. Anil Srivatsava. I don't know anyone. Today I'm meeting them all. I could shake hands with them. So these are all people I'm seeing websites and I've heard about them. So in life, when we sit in conferences like this, just get some information out of it. So you all become good clinicians, good leaders in the profession, and our profession requires leaders. So this is just a small introduction. I was in 2013 in Goa, I think. So that conference in Goa, I attended the second time. So this is the first time I am actually attending a serious conference. So thank the organizers of the conference. My sincere thanks goes to Joseph Sunny, Mr. Sanjeev, Dr. Shovan sir, my mentor, my guide. My classmate is here, Amitabh. I acknowledge the people who know Lakshman, the dean of SRM College, my senior in Santosh, Ram, so many other people whom I know. So thank you all for being here. So my topic. Okay, the previous slide was there's no potential conflict of interest. Actually, I have a conflict of interest here. The reason behind it is, although I'm presenting about technology, but also know that actually I'm doing my PhD in Nova Southeastern University, Florida. So we read a lot of occupational-based models for my PhD. So one of this is occupational balance, occupational well-being, occupational justice, all these elements. So as much as we know about technology, we should also know about occupation-related approaches and how do we connect technology to the final quality of life and occupational balance of a patient. So I don't want to go into details of stroke. Stroke creates upper limb impairments, and all of us know about this. It can be divided into two: ischemic, hemorrhagic. Basically, hemorrhagic causes more problems, ischemic causes less problems. So patients who are coming after stroke in acute stages, they can come first 7 days in the acute hospital. That's called acute phase. Then we have an early subacute phase and the late subacute phase. Cognitive impairment also causes a major problem in upper extremity. So you shouldn't be looking at upper extremity alone. Upper extremity and cognition have a problem. If you have a problem in cognitive area, it will affect the upper extremity as well and the improvement of upper extremity. So suppose if you have a visual perceptual deficit, that has a direct impact on the patient's motivation and cooperation in therapy. So if someone is asking you, what is the science behind? So we are all professionals, isn't it? So anyone who uses technology can be trained in the use of technology. So it doesn't necessarily have to be an OT or a PT. So what is the science? So you should understand what is the impact of corticospinal tract and the function. The primary function of the corticospinal tract is to transmit motor commands from the brain to the spinal cord. And this tract plays a crucial role in the fine control movements. And that there is a direct connection between the impact of corticospinal tract and the impact of how the upper extremity functions later. So the more the impact on corticospinal tract, the more the upper extremity deficit. So we need to understand, and there is a possibility of connecting it. Of course, there are centers which have already started doing it, how to measure it in terms of scientific way of finding out how much of an impact is there and how much is the upper extremity impairment. Like I said, there's a critical time for rehabilitation, the early phase, the intermediate phase, and the chronic phase. So the first few weeks are important. In olden days, they were saying that it's golden days of recovery. So each day after a stroke, The patient is in your hands, and it's very important for us to understand that when a stroke patient comes, the repetitions are important. Why repetitions? So the understanding is there is studies which has told that around 400 to 600 repetitions are required in a given session for an upper extremity, 5 to 6 days in a week for 2 to 3 months for post-stroke. So how do I get 400 to 600 repetitions every day? So this is the question we need to address and in the first phase or the early phase of rehabilitation. So if I say something like this, don't think that someone is saying without some kind of an evidence. We already have evidences. You can always go back and find out some evidences. Why critical? Why early? There are people asking you this question. Why? Why? So when we say why, it's always better to go back to literature. Literature is the best way you can find out. There is a conflict going on between practice-based evidence and evidence-based practice, but it is an integration of both. So if there are senior experts telling us, this is what in my experience, they wouldn't have published. They are not researchers. They are not interested in research. That doesn't make them any less than someone who start publishing. And I've just started doing some kind of publication. We are not into too many publications, but when we start having this habit of how many years of experience we have and we start publishing, we start enjoying the fruits of what we understand. So whoever is publishing in these areas are key for us to go back in the area of the research question you are trying to address. So recent research findings, early intervention infection studies have shown that intensive rehabilitation in the early stages of stroke can lead to better outcomes. And in long-term care rehabilitation also, there are studies which is showing that it is helping. So it's very important for timely rehabilitation. So we have to make sure that everything is very important and tailored approaches, it customize it to the patient's level. So now I'm getting into the concept of neuroplasticity. Now everyone will understand why this therapy treatment has to be intensified. So neuroplasticity is the brain's ability to change and adapt as a result of experience. And it refers to a structural and functional change in the brain's neural network. I'd like to try to play the video.
Adapt and heal after a traumatic event like a stroke? What if it were possible for the brain to rewire itself, to compensate for damage and even restore lost functions? Enter the fascinating world of neuroplasticity, the brain's extraordinary ability to change and adapt. Neuroplasticity, or brain plasticity, refers to the brain's unique ability to alter its own structure and function throughout life. But what does this really mean? It means the brain is not set in stone as one might think. Instead, it's more like a dynamic, pulsating organ, constantly creating new neural pathways and adjusting existing ones in response to learning, experience, and even injury. When a person suffers a stroke, the flow of oxygen-rich blood to a part of the brain gets blocked. This can cause brain cells to die, resulting in loss of the abilities controlled by that area of the brain. The damage can be devastating, leading to paralysis, speech problems, and memory loss. But here's where the magic of neuroplasticity comes in. The brain's plasticity allows it to remodel itself. When a stroke damages part of the brain, other parts can step in and take over the functions of the damaged area. This is the essence of stroke recovery, the brain's ability to reorganize itself by forming new neural connections. This process can be aided by rehabilitation, stimulating the brain to make these new connections faster and more efficiently. The key to harnessing neuroplasticity for stroke recovery lies in repetition and stimulation. Engaging in repetitive, targeted exercises can help stimulate the brain to form new neural pathways. This is particularly important for upper limb rehabilitation, where repetitive tasks like gripping, reaching, and moving can help retrain the brain and restore function. In other words, the brain can be trained to bypass the damaged areas and use other parts to perform the same functions. For example, if a stroke impairs the ability to move an arm, training and therapy can help the brain relearn this skill by creating new neural pathways. In conclusion, Neuroplasticity's role in stroke recovery is nothing short of remarkable. It's the brain's way of healing and adapting, of finding new ways to function when old pathways have been damaged. It's a testament to the resilience and adaptability of the human brain. So the next time you ponder about the brain's incredible capabilities, remember neuroplasticity. Remember that the brain is not set in stone, but a dynamic, ever-adapting organ capable of remarkable recovery and resilience, even in the face of adversity such as a stroke. The understanding and harnessing of neuroplasticity truly is a game changer in stroke recovery and rehabilitation. Ever wondered how the human brain can adapt and heal after a traumatic event like a stroke? What if it were...
So, we already saw the video. I think it's very clear. So I don't want to get into details of what it is. So this is the way of, trying to say why. What are we actually doing by repetition? So we understood the concept of neuroplasticity and why the repetitions and what happens because of the repetition. So recent research findings is showing that the intensity in rehabilitation is actually helping and the repetitive task training is actually helping. So there is plenty of research, like I already have told you, that the repetitive tasks and intensity is important. So now I'm coming to what is happening in Hamad. Hamad Medical Corporation is a hospital in Qatar. And Qatar has a logo, Qatar deserves the best. And they're a very rich country, so they can afford whatever they are affording now. That is so lucky that was part of decision making with the highest levels up to the Minister of Health. So we had an opportunity to start a rehab facility, and that's how they started telling us to find out what are the options available in 2013-14. So we did a lot of analysis to find out what is happening. And one institute which we bumped into, Early Ability Ryan Lab, previously known as Rehabilitation Institute of Chicago in the US. They call that facility as number 1 in the US. The Shirley Ability Ryan Lab, they changed it into Shirley Ability Ryan Lab somewhere in 2016-17. And then they've had labs called Arms Plus Hands Lab, Think Plus Speak Lab. You can go on Google and find out all those things. All the Arms Plus Hands Lab predominantly is run by an occupational therapist. So internationally, we have presidents to say that we run the show. Means that our Hands Lab is led by the occupational therapist. So technology's use, technology's clinical impact is based on competence. So if you're competent enough to lead that program, you will understand that you can be a leader. So it doesn't have to be an OT or a PT in this kind of a discussion. It's more of a competency-based thing. So we formed something like stroke upper extremity rehabilitation program. This technology, there is a lot of other things which we have. The robot devices, neurodynamic splitting, which includes SIBO. There is EMG feedback. There's the functional electrical stimulation, and there is virtual reality devices. So there are plenty of technology available for upper extremity. If you go into search mode, you can find out. But if you want more details of which company and all those things, if someone is really interested to know about it, after the session, somewhere when we meet, you can ask me and let you know where it is. So there is also references for the use of technology. So now this question, you have seen the traditional people, right? The conservative people, the people I think we had already a discussion saying that if you're not AI pro person, or if you don't want to know AI, you'll be lost. You're not a person who can continue to say that I don't think so this is going to work. And I'm not sure whether this is actually affordable. So there's two ways of looking at it. Someone who can afford, and if you're placed in a well-placed hospital in India or elsewhere, where this kind of technology exists, you can always prove to the world that why technology. It enhances motor recovery. So it leads to improved motor skills. It provides tasks. And like I said, if we have to give 400 to 600 repetitions in a day by your hand, what will the patient do? What will the others think? I mean, there's no motivation. There's no challenges. There's nothing in front of you who can prove to say the patient that something is. So enhanced motor recovery, it's customizable according to the patient, how much he's able to perform, which stage of recovery is the patient in, where is the challenges. You can increase, decrease the amount of challenges. So customizing, you can increase the intensity and frequency based on the availability of technology. You have the provision of so many technology available in front of you, and you can decide which to use, which not to use. And that is the reason why clinicians should always understand that technology is just assisting you, like everyone else told you, and it's not replacing you. And if there is an OT assistant or a technician along with you, he or she cannot replace the therapist. So that's why we need to understand the science. We need to understand the concept of neuroplasticity, and we need to also future understand the outcome measure as well. So it gives you real-time feedback. The patient can see what is happening. And we can always say that, okay, this is what is happening, this is improving, this is reducing, or something like that. So the patient can see that, feel that, and you can know he knows he's doing something. It's not a placebo. Some of us think that it can be a placebo. Yeah, in chronic cases where patients might not improve, and even that is a myth, it's an hypothesis. We don't even know how many years after stroke a patient can improve or not improve, because that's not 100% still proved. But after stroke, at least for the first 6 months, every simple small try we give to improve the patient is very important. So if we try doing this, and trust me, I'm doing this for the past 7 years and we are seeing the results. We are seeing patients getting better. We have patients who are not motivated to use technology. So or even if you have randomized controlled trials currently going on, we are not stopping most of the patients in coming and attending this SANS lab. So we see patients improve. It also gives you objective measure of progress. So we can see how much of a progress it does. Improved accessibility and convenience. So you can even take them to the bedside. You have an FES device. And currently we are thinking of giving an FES device to their home, and then check how it has an impact throughout the day. If you wear they say that you can even wear 8 to 10 hours of functional electrical stimulation post-stroke. So they just have to inspect the skin, and we need to educate the patient and the family members for any contraindications. So summarizing this, it enhances recovery, it's tailored therapy programs, it increases therapy intensity and accessibility.
The Zing MPS can be set up as a.
Okay, so next one is, if I say that I did a stroke upper extremity program, so where did I get the literature support from? There is a lot of literature. There's a lot of different names. I selected something which is along with our team, which best suits us. So this is concise arm and hand rehabilitation approach in stroke. These are people from Netherlands, basically occupational therapists. This was published in 2015 in Open Journal of Occupational Therapy. So they have come out with something like this. They divided, they have said that the concise arm provides a structured feedback. The incorporation of technology in upper limb stroke offers a range of benefits in tailored therapy programs, and which altogether contributes better outcomes for stroke survivors. And they've divided it into 3 based on a UAT tool. In Qatar, we use the action research arm test. The action research arm test has a score of 57. So we divided it into 0 to 17, 18 into 37, 38 to 57. And we divide that into 3 different scopes. However, currently we have the luxury for providing care for even people who are severely impaired to get the 3 to 5 sessions. So currently we have 3 sessions, 1 hour of OT, PT and speech. Then we have 1 to 1.5 hours of hand rehabilitation, 1 hour of gait lab, 1 hour of hydrotherapy. So the patient gets 6 to 7 hours of therapy completely free of cost. That's Qatar government's initiative to support currently even non-Qataris, people who are staying there. Of course, insurance is taking up like every other country which is getting into the insurances, and we soon will get into insurance. But as of today, we could provide that care. So the concise and harm rehabilitation approach in stroke includes an initial and final assessment, and the modular sign of training allows flexibility. I don't want to go into details of this. If you can, it is just it's a free journal. I mean, you can open access journal. You can Google and find. So in summary, CARAS provides a comprehensive and adaptable framework for rehabilitation stroke patients and varying degrees of arm and hand impairments, incorporating modern techniques and personalized care approaches. So if I call my program Enhanced Stroke Upper Extremity Rehabilitation Program, I can call it in whatever name I want to. Each organization can use their own names, but you need to have some kind of literature support, some kind of science support, and to say that, okay, this is why I'm doing this. So this is what we call NeurArms plus Hands Lab. Again, like I told you, the Arms plus Hands Lab is the name given in the Shirley Ability Ryan Lab. So we took that name from there. But to tell you a secret, even before Shirley Ability Ryan Lab called it Arms plus Hands Lab in 2011-12, we wanted to call it as a lab. But of course, we always have this small thing of following the Americans wherever we want to. So it's good that they also came out with something named Arms plus Hands. They don't call it neuro, but we have a very specific ortho hand. People like shown sir in India, we have Miss Monique and her team. They're all certified hand therapists. There are around 10 certified hand therapists working in that hand program. So we had a conflict to differentiate ortho hand and neuro hand. So we call this Neuro Arms plus Hands Labs just to differentiate and tell the world that we are two different units within occupational therapy. And our chief was very happy because whenever it suits him, he just says that this hand lab is better and that land lab is better. So NeurArms plus Hands Lab represents an innovative approach. It's blending cutting edge technologies with personalized care. So we have a process in place of how and when to select a patient. So this is just a small picture of some CPM. Some people will ask you why CPM. So initially stages, we just still need CPMs. There's already a lot of research which shows that CPM also helps in stroke. This is the action research arm test. So we just said that we will have a minimum score of 20 as a difference between initial and discharge. And we put as 30% of the patients will get that score, our hypothesis. So when we started improvising, we have an outcome measure, which is action research arm test. And we have a idea of how to get this score, initial and discharge, and compare the initial and discharge so that we know where the progress is. So this is the hands lab based on the Karas article classification. So functional hand, supportive hand, non-functional hand. So similar classification is also available using the action research arm test. So our services offers the follows not limited to it's upper limb focus assessment, a thorough discussion of goals, advice on symptom management, and team finds appropriate. Then we have 5 sessions or 6 sessions because now we have even the Saturdays, which we have included. So 6 sessions of 1 hour minimum up to 2 hours of therapy only for upper extremity and hand, along with the 1 hour of therapy of OT, which we give for self-care, functional mobility, and other things. So we need to have a rational. So we have a rational of primary and secondary, and we are trying to standardize and create a like a pattern so that we can tell the world that this is how we can integrate technology and convert. So, I think there is a topic about detail about FES. So we have 3 kind of FES just for the sake of understanding, which we are using. So I want you to know about it. One is the Bioness, the H200. That's the first one. And then we have something called REGRASP, REGRASP. And then we have a XFT. XFT is from China. So these are 3 different brands providing almost similar functions. And these 3 we can help you in terms of, initially using the functional electrical stimulation. And what does functional electrical stimulation do? I think there's a lecture about it from one of our speakers. But you can always find out what does it do, how does it improve, where how do you wear it, how do you get it. It's a very simple thing to get trained and use it. Neuro hand splinting, people who are interested in splinting will understand that neuro splinting is a little bit tricky. And we also have, we can customize it, or we can also use the ready-made ones. One important thing is the SIBO, which we have in Qatar. So people, I think I have heard in Neuro in Bangalore has SIBO. If people have used SIBO already, you will understand the impact of it. All the splints are made by a person. So a person who makes a splint should love splinting. So it's not one Showan Sahar, one Harris Monova in Qatar, who is the only people who can make splints. I would encourage people who are here to take splinting as something which you love. Of course, it was never in me. I got trained by him, but I could never become like him. But if people are really having the skill of splinting, I would kindly encourage you. It's a very good skill for you to have. It doesn't have to be a boy, a male always. If females are good in whatever you do, please go to the splinting room whenever you are free. Try splinting, it's a good skill to have. Okay, so if some people are asking us what next, so we started doing research. There's already retrospective study. There's already a prospective study going on now, and the latest prospective study is about use of functional electrical stimulation at home. So the NURAMS plan stands in summary. It exemplifies the integration of technology and patient-centered care in stroke rehabilitation and offers hope and advanced therapeutic options to those recovering from upper limb impairments due to stroke. And trust me, there are so many people who will say, first, I want to walk. They will, because everyone is becoming very dependent after stroke. So the first goal, they'll say, and most of you will agree to that, I want to walk. Sooner or later, they'll start realizing they're walking already with some kind of assistance, or some people walk even independently, and their arms and upper extremities not moving, especially the shoulder and the hand. How difficult it is. Suppose because our average age of stroke population is 35. It's not like, I don't know what is the average age in India. And considering the current food habits, the stress and everything, the heart problems and stroke and everything is so it comes in a very young age that they are breadwinners of the family with children left behind, and wife is not working and all those things. So we have philosophy-based profession, and we have humanity and empathy embedded in our profession. So think loud and look and understand from the patient's and the family's perspective, are we doing enough? Are we actually giving the care which we are supposed to give as an OT or a PT or wherever we are working? So in your organization, the limited scope you have, think about. So this is just we are just simulating using the BT.
The Rehabilitation Institute, QRI, modern and well-equipped rehabilitation facility offering an array of rehabilitation services, one of which at the lab, patients undergo extra therapy sessions to rehabilitate their arms and hands after suffering upper extremities motor impairments. The Neuro Arms and Hands Lab is an environment designed for patients to improve arms and hands performance whilst recovering and strengthening complex hand and reaching skills, which improves independence in functions and activities of daily living, such as dressing. This initiative, being run in a lab environment, has given promising results in several patients. Upper extremity motor impairment is the most common source of disability after a person suffers from a stroke, with most of the spontaneous recovery occurring during the first 3 months. Injury to the corticospinal tract at our Rehabilitation Institute, QRI, is a modern and well-equipped rehabilitation facility offering an array of rehabilitation services, one of which is the Neuro Arms and Hands Lab therapy sessions within its Occupational Therapy department. At the lab, patients undergo extra therapy sessions to rehabilitate their arms and hands after suffering upper extremities motor impairments. The Neuro Arms and Hands Lab is an environment designed for patients to improve arms and hands performance whilst recovering and strengthening complex hand and reaching skills, which improves independence in functions and activities of daily living, such as dressing. This initiative, being run in a lab environment, has given promising results in several patients. Upper extremity motor impairment is the most common source of disability after a person suffers from a stroke, with most of the spontaneous recovery occurring in the first 3 months. Injury to the corticospinal tract
I think the video has some problems. Just go to the next slide. So we have upper extremity now. So we need to look at cognition as well. So I've just basically just given you a slide on how cognition is divided, or however we can divide it in whichever way we want to. And there's some basic cognitive skills, higher level of cognitive skills, meta processing skills. So we have a process, we have an assessment, and then we have intervention for cognition. We have tools. And then I just want to just tell you that whenever we want to do some assessment, we need to be clear that we do a screening criteria. If there's a screening criteria available, MMSE is there, Montreal Cognitive Assessment is there, Aaron Brooks is there. So whichever is there, you can use it. Now, I think MMSE, if I'm not wrong, has started becoming paid one, but I'm not very sure whether they changed it. And MOCA is there. You need to be trained in MOCA. So you need to do that. There's always a detailed assessment which you can use using LOTCA and RBMT or balance at the leatherizing task and functional based tasks. So FIM, for now, if you want to use FIM, you need to be trained and certified by the UDSMR was the previous one, they changed it. So we need to be certified. We need to be certified in the use of Canadian occupational, we can purchase it and then that certify, and then we need to. So all these assessments are necessary for us to understand what technology we are using and why technology. So this is the technology-based stroke cognitive rehabilitation, small area for outpatients. We have it in inpatients as well. So this is where we have put all the technology together. And I just want to highlight on few of the technology which is already available for cognitive rehabilitation. One is the Bioness integrated therapy system. This is from the Bioness company. Currently, the bio vendors. So they have this technology. Currently, it cannot be sold from outside the US. We were lucky enough that we purchased it 5-6 years before, and we have 5 or 6 units. So this is basically doing an assessment of what we were doing as pencil, pen, all those tests which we're doing on the tabletop. We can just integrate that into a system. So this is that. We also have, I think some of the institutions have already purchased something from Triera Motion in India. There's something called Myro. Myro is also a very good device which can help in cognition. We have Rehab Metrics, and currently we also have Retouch. There are a lot of other things which is already available. So you can go and find out. So these technologies should be there for you to take assistance and take clarity from how to use it. So in the journey of stroke, technology is not but a bridge connecting capabilities of new possibilities, transforming recovery into the path of discovery and empowerment. Before I conclude, I just want to, I belong to a state called Tamil Nadu. So there is something called Tirukkural. They say that எப்பொருள் யாரார்வாய் கேட்பினும் அப்பொருள் மெய்ப்பொருள் காண்பது அறிவு. So if you are using your knowledge and understanding that whatever I said or whatever any speaker is saying is the best, that's not correct. You have to go back to literature. You have to for yourself whether this works, doesn't work, which organization requires, which organization doesn't require. What is the difference between high-level technology, low-cost technology? How do I change and improvise as an occupational therapist to use the same technology, which my counterpart in Qatar, called Mr. Salah Adarbe, who actually had to be here today, and he was one of the first persons to register for this conference from there. Coincidentally, for some reason, he was not able to come because of visa processing. He does a lot of low-cost technology and so many things that we cannot only say that high-level technology, high-cost technology is the only thing in the future. So it's a bit of integrating of all these things together and ideas from the therapists, the leaders, working together without any kind of bias, without any letting go. I know it all concept should go off. Let's all listen from each other because today's youngsters are very good. So I'm 45, so I listen to somebody who's 22, 23, joining my unit and telling me this idea is better, that idea is better. So it's like a combination of all these things which makes the patient at the center. So when we say patient-centric care, it's not about one person doing it all. It's all about everyone doing together. And like I said, our profession is a philosophy-based profession. So love everybody, be a good human being, be good youngsters, come out well, be very, very successful in life. And thank you so much.
Thank you, Dr. Isaac, for a wonderful lecture. And yes, you have rightly said, the artificial intelligence is to assess human brain, not to replace the human brain. Provided we keep an update of our professional skill and knowledge, to continue on the path journey of the same. We will continue with our next program with Dr. Nekram Upadhyay, And unfortunately, due to unforeseen reasons, he could not come here physically. So we'll be having his lecture through online mode. Dr. Nikram Upadhyay. What is
Check. Check. Check.
Yeah. Dr. Nikram Upadhyay is head of the Department of Assistive Technology at ISSC. He is also a lecturer for ISSC Institute of Rehabilitation Science. He is a PhD scholar. He is a member of many national and international scientific societies and organizations like World Disability Rehabilitation Network, WHO Global Cooperation of Assistive Technology, and also he is a recipient of various awards and the fellowship programs, including the Gold Medal by the Spinal Society of India, and also a Ford Foundation International Fellowship Award. So we'll be having his lecture through online mode for Dr. Nikram Upadhyay. I would like to help our technical team to connect with Dr. Nikram Upadhyay through online mode. There is some technical glitch. They are trying to connect with our honorable speaker.
Dr. Lakshman, you have my recorded video, right? Special thanks to Dr. Jyotika and Dr. Neeraj Mishra for inviting me for this session, the IOTA conference. And I'm Nekram Upadhyay. I work at Indian Spinal Center. I look after the Department of Assistive Technology, where we provide assistive technology services to the people with spinal cord injury and other people, those who similar conditions. So my talk going to be focused on purely assistive technology, devices, and the service provision, how we deliver the product to the end user. So what kind of assessment process that we follow and what sort of customization that we do, and then how we give the training to the user to use the particular product, and then how we do the follow-up to people with spinal cord injury, those who come to us. I'm keeping it to purely assistive technology services and products, as previous speaker already spoken to on artificial intelligence, and other speakers going to talk about the same topic as well. So I wanted to keep this my session on purely assistive technology, products and services, and end user needs, how we can match their requirement with the assistive devices. So look at if you think about assistive technology, if you people now coming to understand how assistive technology is very children with also people with which we deliver that product to the end user. So for us, it's a product and the end user, and what process to be followed right from the assessment to customization, the selection of the equipment, and do the certain amount of customization and fabrication, and then provide training to achieve the independence. So to go to the little bit background, as you already know that the ICF classification on functioning and on disability and health model suggests that every person has a right to be actively participated into the community and lead a good quality of life. So this particular model, having any health condition due to certain impairment, the person is not able to achieve their independence and not able to participate fully in the community and the society. So how, what sort of procedures and to be followed to make them more independent enough so they can actively participate, rather having different type of factors, in terms of policy or funds or their psychosocial conditions, or maybe there could be disability. So how they can these factors can be avoided still and provide them independence. So to match that need to the end user, we need to focus on developing assistive product to achieve the independence, to perform the activity, having that disability. So in our case, like if you have a spinal cord injury, then of course they want to do certain activities. So what sort of assistive devices that can be provided to make them more independent? Assistive products or assistive technology product or assistive devices that has a range, this a whole range in terms of the affordability. So it could be low cost or it could be very high cost. In terms of technology, it could be very low tech or it could be a high tech solution. So low tech, like just adaptive spoon, like you all experience in your clinical practice. But then there are some high tech gadgets like exoskeletons and high tech electric wheelchairs. So assistive technology is not just limit to one particular stage, it has a whole range. To support that assistive technology provisioning and services, the World Health Organization has come up with the Global Cooperation on Assistive Technology. that focuses on 5P model. So it's a people, product, personnel, provision, and policy. So people, those who need assistive products or assistive technology services. Then, of course, products are the assistive devices. The personnels, those you're going to customize and deliver and going to provide training. So those personnels, the skill set of the professionals. And then, of course, the provision that we need to follow the path. What kind of service protocol to be followed to deliver that particular product to the end user with the different kind of, the customization and fabrication that is required for to match the need of the individual. And then, of course, the policy has to drive the whole scenario, the synergy. And so what kind of policy at the government level, at the national level, or at the institutional level, or at the hospital level, or the clinical level that we delivering. So what kind of policy we providing to achieve this whole process. So assistive technology for spinal cord injury, we mainly focus on, the personal mobility. So how they can be independently mobile in their, living areas or working areas, or at last.
Sorry for the poverty. We are putting the presentation pause. He'll be joining to live demonstration.
So can you hear me now, everyone? Am I audible?
Yeah, Dr. Nikram, we can hear you. I can at least hear you.
Oh, yes. I don't know what is happening that end, but anyway, I think that's good. I think they would be also be hearing you. I think, so I think the slides can be continue at that point, and then I can continue from here, right? Dr. Lakshman, Neeraj, anybody is there I can talk to? Matt, already
Kindly
live.
stop this presentation. I would like to request our technical team to kindly hold the presentation on pause. Kindly pause the presentation, please.
So yeah, okay, I unmuted. So sorry actually for technical fault, and I think till here you must have been listening me listening me hello. Okay, so that's good. Please echoing. I don't know for some reason. So the voice looks better now. Okay.
Yeah,
So-
yeah, please go ahead, Dr. Nikram. It's all right.
Okay, so it looks okay. Thanks, fine. So let me start from here onwards. So basically in the assistive technology for spinal cord injury, we have 5 or 6, domains that we work for. So of course the personal mobility, because most of the people after the spinal cord injury, they are not able to be mobile enough. So how we can make them independent by providing a good appropriate wheelchair. So of course the selection of their personal mobility, be it a manual wheelchair or a motorized wheelchair, that is altogether a task, and selecting a wheelchair in Indian scenario and customizing that to the individual or to suffer from spinal cord injury, having different challenges, then of course we need to, really focus on that. So what kind of process, what type of wheelchairs, what modifications are required? So I'll go in detail. Then second thing, we look at the seating and positioning. So the person who sits onto the wheelchair, then we need to focus on customizing that also. So the wheelchair has a two component. One is a mobility, the other part is the seating. So what kind of seating mechanism to be provided to prevent the bed sores or any skin conditions breakdown and then other deformities? So how they can sit longer onto the wheelchair to work or to be more actively involved in their personal task. Then of course we look at the activity of daily living devices and products and that to a custom made for individual. So each individual has their own needs and their own conditions. So how we can custom made the assistive devices for them for their daily activities. People those who suffer from quadriplegia, they lost control in their hands. So how they can still operate a computer and mobile phones? What kind of accessibility features or assistive technology applications or devices can be given? Those so they can be interacted with the computer systems and mobile phones so they can be more communicative and be independent. And what sort of environmental control units can be provided for home or offices or even in the transportation accessibility, so look at to make them more independent. So to do this assistive technology service delivery process at Indian Spinal Center, we get the referral from doctors, therapists, and sometimes the self-referral. So people come with their self needs to directly to the assistive technology department. We have a team of including physiotherapists, occupational therapists, then myself, rehab engineer, technicians. So we do the thorough assessment of the person and then do the measurements and try to find out their needs and challenges and select the appropriate products. So if it's about wheelchair, then of course look at the different kind of wheelchairs according to their different needs. And then of course do the complete customization real time, having the person in the clinic. Then of course the training required to how to handle and how to use the product and proper follow-up, even after delivering the product. So that is basically the process that we follow. So the wheelchair has a number of components inbuilt. It's not just a frame and four wheels. It has got number of parts that needs to be customized. So if a person is not able to operate the brake onto the wheelchair, then the wheelchair is not customized enough. Right, the person is not able to propel itself. The wheel positioning is not appropriately positioned in the wheelchair. Then the person may not be able to propel fully, or they require some assistance to the push around. So each component has their own different customization according to the person's sitting and positioning and their conditions. So of course we need complete measurement, the seating and width and depth and back height, the footrest and armrest positioning. So everything has to be measured and the wheelchair has to be customized. So wheelchair are there which comes in different sizes. Then the further customization can be done. So if you look at these two pictures, the same person sitting in two different wheelchairs, the one is not appropriate, but the other one is appropriate. Well, that makes a lot of difference, when the person is sitting like in appropriately positioned onto the wheelchair which has been given, but the same person can be put into a customized wheelchair to achieve their, self-esteem, good quality of life. They're propelling by himself, being a quadriplegia, doing a little bit modification in the push-rim. So the person is able to propel by himself also. So there are different kind of complications might occur if you do not customize the proper wheelchair. Of course, you can get shoulder pain if the armrest or the rear wheels are not in position. There are high back support, though the person is not required, then of course they cannot propel. So what kind of modifications can be given to cater these kind of complications? There are different kind of wheelchairs that can be picked from the the stock that you have. So of course the one clinic should have all range of wheelchairs in your clinic or your center or whatever you call it, assistive technology unit or department. you must have all these wheelchair available in front of you. The user can select, you together can select with the caregiver involvement also. Then further customization can be done. In terms of the motorized wheelchairs, there are n number of motorized wheelchairs nowadays available, the low cost, high cost. The different kind of power functions, standing features, recline, tilt, based on the requirement of the person with spinal cord injury. If it's a quadriplegia is working, can afford, then of course we can think of giving a recline and tilt wheelchair so the person can sit on the wheelchair for longer time and can walk properly. Some people may require standing wheelchairs, so there are type of wheelchair, but then of course you can go to low-tech customized wheelchairs also, which can cost around 60 to 70,000 rupees. The person can still be mobile, but then if you want to reduce the cost of a same wheelchair, if the person is not able to operate the joystick, the existing joystick, so how you can customize the joystick controller with for related to the quadriplegic hand, right? So these kind of alterations we do. If you look at this individual is a C5-6 level quadriplegia, how he can propel still, so just Professor Sovans, I can very well make out with this, looking at the little splint that we made in the, just like a universal cuff. So this person is just sticking this into the joystick and he's able to operate, rather though he was not able to control the knob of the joystick. So we just made this customization. So this quadriplegic don't need to go for a high-tech wheelchair, right? And then if you look at the other picture, the same joystick can be attached to a joystick. So this is kind of modification can be done in the same wheelchair. This is just me, a few years back. So the joystick just attached to the chin, rather having very high-tech sip and puff or maybe head control or other switches, of course, that can cost a lot. But then same wheelchair, which cost around 50,000 rupees, can be converted into a chin control operating wheelchair. So like this high level of quadriplegia, maybe a C4 level of injury, can operate, the chin control wheelchair. If you look at the previous slide a little bit fully, then you can make out this quadriplegia. How you can turn, how you can approach. And you might be thinking that how you can turn on and turn off the joystick. So same splint, I did not make a video, but he can take off this splint. Then we made a little pointer, just attach little pointer so you can just touch these buttons, though he cannot put the fingers, but then so he was able to operate the joystick. So if you look at the seating after the wheelchair mobility, of course, there are a number of cushions and supporting devices can be provided onto the wheelchair to make the person properly positioned. So different kind of cushions, be it foam, gel, air cushions, based on their need and affordability, and the level of sensation that they have, history of pressure source they have, or maybe a current pressure source they're having. So what kind of cushions can we customize? So we do have a pressure mapping technology, like we do pressure mapping assessment through this pressure mapping seat. So we have a sensor seat which is put onto the wheelchair seat and the person can sit onto the sensor seat. So we can get a biofeedback onto the computer which calibrates the pressure points. So that's where we call it a wheelchair seating pressure mapping system. We can make out how much pressure is being built where. So if you look at this little video, I can just skip a little bit. So that's how this pressure mapping system works. It attached to a computer which has an application which calibrates the pressure points. So the red marks are the higher pressure areas and the blue marks are the low pressure areas. We would like to achieve the all blue parts, right? So this is without a cushion, the person sitting without cushion onto the seat. But then if you put the cushion, then just to put a cushion and then sit it again, if you see the screen, this all changed to blue or light green. But there means there's no red areas. So that means the seat is being provided, releasing the pressure. So this is different kind of gel cushions available. And then you look at the, so apart from the seating and mobility, so there's one more I would like to, especially for students, because every clinic might not have a pressure mapping system. So this particular video made by WHO for resource countries, this particular assessment, the hand simulation assessment for occupational therapists, you simply can do it. Any therapist can do it for pressure mapping.
Morning. Hello. How are you? Hi, I'm Lauren. We met last time when we gave Alison her new wheelchair. Okay. Now I want to check underneath to make sure that the cushion is okay. So I have to put my hands underneath where you're sitting. Is that all right? Okay. Okay. Alison, I'm going to get you to lean forward. And come back. Good. Yeah, that's okay on this side.
So what he's trying to do is he's putting the hands under the IT, the Institute University, and feeling, how much.
The other side. I want you to lean forward and lean back. Back. That's also okay on both sides. All right, so no worry.
If you can turn off the mic, please. So yes, so this was basically any therapist in the clinic, those who deal with the spinal cord injury or those who are prone to get bed sores, they can do this hand simulation assessment, for the pressure. Even you can train the caregivers so they can keep on continue doing at home, if the cushion is break out or the surface they're sitting, even in the supine and prone positions, you can still assess your bed or mattress, how much pressure is being built onto the bony areas, the pressure point areas. So that pressure assessment can be done by the hand with the level 1, level 2, level 3. The another thing that, of course, the spinal cord injured, those who are quadriplegics, they need a lot of assistive devices for their hand. So for feeding, brushing, writing, typing, all these activities, of course, they need some sort of assistive devices, splints. Then how we can make them customized to according to the different, so we have a workshop. We in-house we make custom-made assistive devices for different type of activities. So people, those who can work on a computer, having different kind of splints. So first we try with the splints, making out of maybe low temperature plastic and any different kind of materials. So we try to achieve their reading, writing, typing, and working on a computer and mobile phone with some sort of assisted devices, being even quadriplegia, C5 or C6 or sometimes C4 level of injuries. If we are not able to achieve with the splint, then we can think of giving some sort of assistance. So if you look at this small splint, finger is able to work on a keyboard. Of course, this is a very simple splint. Anybody can make it. But if the innovative part or the good part of this, we are not using the pointer of a plastic, we're using the finger. So the same finger can be used on the touchpad. So the same keyboard as a touchpad. So you don't need a mouse. So we can, remove the mouse. So the keyboard comes with the inbuilt touchpad, which is wirelessly connected to the computer. And the person can press the keys through this finger. As well, at the same time, he can touch on the touchpad and operate the computer also, right? So the same splint, most of the time people make splint with the plastic pointer. So we are not making a plastic pointer. We supported the finger and make the finger as a pointer.
So still the person can work on touchpad as well as the mobile phone. So because it needs finger touch. If you look at his hand, right? If you look at his hand, though he does not have a, is it like fair wrist control, but not appropriate, but still is able to do it. But if we have a patient, those who come without having wrist control, then we can kind of extend it to forearm, up till forearm, right? So that splint can still work the same splint. So you can extend this up to forearm and the person is still can operate. So he's like C6 level of spine cord injury. Though your C5 does not have a wrist control, then you can extend it to the forearm support. To the next. Then of course, we have a voice operating softwares people use through voice, those who cannot operate their hands with the hand. So the voice operating recognition software, there's another application. Then there's a very open source, low cost, I would say no cost, open source application, which is called Camera Mouse. So every iPad or a laptop or even normal computer, we have a web cameras. Through web cameras, you can operate a computer. So how it works, the camera sees the face of the person who's going to operate the computer. Then we need to make out make a pointer onto the face. So let's say in this example, if you can see, there's a pointer made onto the nose. So the application recognizes that particular pointer. So the nose is being recognized now. So the person can walk on the computer like this person is working. So this is a setup. This is a camera here. And this is a C4 level of quadriplegia sitting in front of the computer. The camera is looking at his face. We already marked his face or his nose. So that is being converted into a mouse. So just so now if you see the cursor is moving onto the on-screen keyboard. There's an on-screen keyboard. And so he's navigating the screen, putting onto the on-screen. You can open any file, and we can fix the timing of the clicking. So maybe 1 second or 2 seconds, if you hold on to particular point, it will be automatically clicked. And this application called Camera Mouse, which is freely available, anybody can download. And this is very good application for high level of tetraplegias, those you can operate the computer with their hands, right? So let's move quickly to the next. Then, of course, there are other solutions for home or maybe for a recreational or listening music, controlling some appliances through smart speaker, smart switches, through Alexa, OK, Google, and Siri. These are also nowadays assistive devices, though they were like mainstream technology, but can be used as assistive technologies also. People with a spinal cord injury, they are also having issues in dealing with their bowel and bladder management. So they always dependent on their family members. So what kind of assisted devices can be made to insert the catheter, being a quadriplegia, how you can still insert your catheter, be a female or male. So what kind of assisted devices can be made? So there are a number of splints or custom-made catheter clamps or suppository inserter, digital stimulator to stimulate your anus to clean your bladder or the bowel. And how you can independently insert your suppository without having any other assistance. So these devices are also we make here in our clinic because that's why we focus. You cannot find such solutions elsewhere. People don't really focus on these solutions. But since we are a tertiary center of spinal cord injury center, we focus on customizing the device for each and everything. People come with a lot of issues for their sexuality issues, right? So what kind of assistive devices can we develop to also cater to that particular need, also being a spinal cord injured? So there are a number of assistive devices can be made for like special vibrators or maybe some suspension system for performing, positioning, and all those things. So these kind of assistive devices and custom-made positioning devices can be made. Then, of course, those who discharge from the hospital or they're dealing their life in a wheelchair, they need a accessibility in the environment. So home accessibility, workplace accessibility, the public places accessibility. So we also guide them what kind of limited modifications you would be needing at home. So making your bedroom, bathroom, entrance of your house or a kitchen area or whatever limited areas, what the measurements, how you can customize your house so you can freely live independently in the house and move around easily, even in the workplaces and offices. So we do guide them. So we ask them for taking pictures and videos of your office or a workplace or a house, so we can then simply do the assessment and guide them. Sometimes we do visit home also to see their homes and guide them for home accessibility and modifications. We also tell these newer and fresher spinal cord injured that there are accessibilities out there in the public, transportation. The metro, you can simply travel. So what is the process, how you can still travel into airlines, airplanes, you can go in the taxis. There are solutions to put up ramps onto, your personal vehicle, how you can modify your car. You Some paraplegia, they do drive their own four-wheeler vehicles, their cars. So how you can make it hand controls. So basically what I'm trying to say that the spinal cord injury need all these technological solutions to lead a good quality of life, being independent and be self-reliant and employed, get employment also and get education done. So these some hand control assisted devices can be put into any car, can be made hand control. So this quadriplegia, if you look at, he's able to drive.
This is sort of a busy road. I'm going to go a little zigzag to show the control that you can have.
Yeah, so these are the basically solutions I wanted to focus on. We do have a training programs on assistive technology. We run assistive technology for the fellowship program for professionals and students, those who want to understand our work, and mainly assistive technology for spinal cord injury and otherwise also. Now we going to open the pediatric center for assistive technology, that is also underway. So we do have a master's and a bachelor program in physiotherapy and occupational therapy. We do have around 500 odd students. So we do try to give them opportunity to understand, what services that we provide. So they come to the assistive technology department and get good hands-on, practice. Sometimes they do develop their own product. So I do teach one of the course on occupational therapy, first year MOT. They have a course on assistive technology. So I do take some classes and give them exposure, try and let them know how to develop and customize products. So they sometimes do come up with the very good solutions. So some students really make different assistive devices in the lab. So that's all. We have some recreational work. So these all patients roaming around in the hospital. Some glimpse I wanted to just showcase how they being very happy in their customized equipment. That's all I have for today. And I really wanted to keep it just to assist to technology, just to our work for spinal cord injury that we do. Thank you so much. And sorry for the, I could not make it this time, but I'm sure in coming years I would be there physically. Let me stop sharing. Yeah.
Good morning, everyone. Is my screen visible to all of you? Please confirm. Please confirm if I'm audible. Okay. So thank you very much for the organizers to give me this opportunity to speak about my work that we are doing on functional electrical stimulation for spinal cord injury and stroke patients. Let me check this. So probably I'll just give you a few ideas on what is electrical stimulation. So this is nothing but injecting the electrical charges in the muscles artificially. So the idea is that if there is any disruption between the muscles and the brain communication, so can we try to establish that communication from outside artificially, and that is what basically FES is. So this is what is being shown here pictorially. Then if you see, this is the basic physics of how this muscle activation works. So basically there are two electrodes, we call them anode and cathode, and this anode and cathodes are, helping us to make a closed circuit for, charge distribution in the muscles or in the nerves. So through this, this functional electrical stimulation, what we are trying to do is trying to recover the functionality in a stroke patient as well as in the spinal cord injury patients. As you see in the title, along with this FES, we are deploying the AI algorithms as well to understand that how the fatigue analysis can be done in the stroke patient, which is very important while giving the FES. And why it's important is because these electrical stimulations, they do not recruit the muscles biomimetically. Like how your brain recruit the muscles is in a very optimized way to optimize your metabolic energy, to optimize the outcomes of the functional movement. However, when we are giving these stimulations from the outside, it's very difficult to actually, optimize the muscles, because when the charge go inside your muscles, it's very, very difficult to control it specific for a particular muscle fiber. So what happens is it goes across the entire muscle fibers, which leads to the fatigue easily. So that is one of the challenge. I'll show you. These are just the demographics of the stroke, and I was told that I have to speak for 25 minutes, so I'm just skipping all these. This is just an example of how do we give the FES. So you can see there is a electrode which is anode, and there is a cathode, and from here we write certain algorithms, and you can see if I give the stimulations here, you can see that some unwanted movements are also there, and that is because you cannot specifically control the muscle fibers within the muscle. So why muscle fatigue is one of the bigger challenges? Because generally, if you see across the physiotherapist or occupational therapist, there is no such guidelines to decide on the waveform that is given to the patient while giving the FES. Means there are various waveforms. Like I'll show you some of the waveforms. How do we give it? So there is some mathematics which I am just skipping, but there are three kinds of waveforms that we generally give. They are called rectangular, which is very standard, and then trapezoidal, which is like you give the stimulation, keep it in a ramp fashion, and then keep it hold for a while, and then you ramp it down. And these are two popular waveforms. Although they have been in the literature and in the clinical settings for a long, what we thought is that can we generate the waveforms which is more closer to how brain actually drives our muscles. So for that, what we did was we collected the EMG signals from the participants, and we factorized these waveforms to calculate what are the muscle synergies for a given individual. So what we did was when we calculated the muscle synergy for a given individual, from that muscle synergy, we created a waveform which we decided to drive the electrical stimulation. So it's basically we are trying to develop a waveform for the stimulation, which is as closer as the brain sends to the muscles when we are kind of healthy person. So the idea is, first we have to identify that what kind of synergies the brain develops for the muscles when a certain task is being done. If you can calculate those synergies, you can send your electrical signals for the stimulation in the same covering of these waveforms. So that is what the idea is. So what we did, we first calculated the EMG signals from the healthy individuals and then created the synergies. Once we find out what are the synergies, then we drive the FES like this. So these are the synergies. You can see that these are the synergy vectors coming from the EMG. And then from that, we map it to the FES, electrical stimulations. You can see here, these are the muscle synergy patterns which we get from the. So these are basically, if you see here, this waveform, if you focus on my cursor, this waveform and this waveforms are quite similar. It goes up, stay there for a while, come back, and then so it goes up, stay there for a while, come back, and this. So now after getting to this muscle synergy pattern, we want to drive our electrical stimulation based on this waveform. So what we did, we created three waveforms. These two are already being used in the literature, the upper two, and third one is kind of developed from our research, which is muscle synergy based. You may see that it is very close to trapezoidal, but this one has been derived from the healthy individuals. They are not, kind of mathematically driven. They are driven by the data collected from the subject. Then what we did, these are our EMG sensors. These are the two pair of electrical stimulation sites, and there is the goniometer. The goniometer is needed to see the functional outcomes of the patient, how much angle they actually reach to after giving. So the stimulation frequency was set to 40 Hertz and the pulse width was 200 microseconds. This is the entire setup. This is a schematic of that. This is a EMG sensor. This is the goniometer, electronic goniometer. These are synchronized with the EMG signal sensor and then recorded in the time logged fashion. This is the algorithms in the G, which calculates the muscle synergy pattern and then drives you can see the electrical stimulator. These are the details of the patients that we recruited for this study. This is the entire setup. You can see all these are electrical stimulator, then EMG, then algorithms to write this is the video you can see for the data collection. So you can see the patient is able to reach to the desired knee angle, which is given in the algorithms, and simultaneously the data is being recorded for his EMG. And this is the EMG signal that we record. Unfortunately, the EMG signals get very corrupted when we are simultaneously doing the FES. And this is one of the biggest challenge in the engineering right now, that how to, what happens is at one side, you are giving the charge to the muscles, and at the same time, you are recording the EMG signal. So these EMG signals, while recording with FES, gets corrupted and get a lot of noise. So there are certain filters available, and we also developed certain filters to remove the FES induced noise in the EMG. And then what we did was we calculated the muscle fatigue for each cycle. You can see first cycle, eighth cycle, and fifth cycle. And then what we did was we calculated the myoelectric indices of the muscle fatigue, like, median frequency, which is a gold standard to quantitatively assess the fatigue in the subjects. So what we observed was very interesting. I'll come back to the results. If you see these three graphs, so the black one is basically the rectangular FES. The red one is basically the black one is actually the synergy based FES, and the red one is basically the trapezoidal FES, and the blue one is basically your rectangular FES. So if you see, and the x-axis is your cycles. So if you see, the peak angular displacement is on the y-axis. So as you can see, that peak angular displacement dropped very heavily when we provided the rectangular FES. It was better in the case of trapezoidal. From the red, you can see it did not get so much of down after almost 30 cycles. However, if you see in the synergy-based FES, you could see that the patient could sustain almost the same peak angular displacement even after 35 cycles. So what we observed that probably by giving the muscle synergy kind of FES, you can minimize the fatigue phenomena in the patient. Otherwise, you can see in the rectangular one, the patients are so fatigued that they drastically reduce their performance after 30 or 35 cycles. So these are the consistent result across the population as well as across the individual. This was one of the very remarkable study and published in IEEE Transaction, which is one of the topmost journal in electrical engineering, where we showed that by giving the muscle synergy based electrical stimulation, we can minimize the fatigue effect of the FES. And this is the article we published. Professor Venugopal V. Vishnu is from AIIMS, Delhi. He's a neurologist. If you want to, I have skipped the detail on the engineering side just to minimize my talk on the given time. But you are most welcome to understand and read this paper. And if you have any further questions, I'll be happy to address by email or at the panel discussion. These are the outcomes of the study. We say that muscle synergy-based stimulation patterns sustain the kinematic output for longer duration and induce less fatigue when compared with the conventional stimulation pattern, which are customized rectangular and trapezoidal waveform. The other study that we did on the, which is very important for from the occupational therapy point of view, is that can we develop certain algorithms which can actually, predict the fatigue? Like so for example, if a patient comes to you and you want to give some repetitive passive movements to him, so how do you decide on that how much is the optimal doses for that patient of repetition? So maybe you give 20 repetition, you may give 19, you may give 13, or you may give 24. So unfortunately, the problem here is that this phenomena of fatigue, non-fatigue to fatigue is not a transient one. It's a sloper one. It's like there is a little gap between the getting from non-fatigue state to the fatigue state. And if you can find out that sweet spot, where is that of stimulation, so actually you can do a very efficient and optimal rehabilitation. Like if you go less than that, you are underutilizing the residual ability of the patient. However, if you go beyond that, you are overusing and you may even get the muscle injury. So finding that sweet spot is a very challenge because it varies across the patient, it varies across the injuries and all these things. So we thought it's very difficult to do it mathematically. So can we do it via, some AI algorithm? So what we did here is, so overall the idea is to develop a neural network model, a deep learning model, which can forecast the myoelectric indices. Like for example, if the patient comes to you and your record is only 2 cycles of EMG, can the AI algorithm predict that if I continue those, what will be the EMG signal at, let's say, 18th cycle, 20th cycle? And then after AI tells me all these, I can decide on that what is the optimal repetition for that particular patient. So this is the neural network that we have developed. So I'll not go into the detail of that. The pattern or the experimental setup is nearly the same. So I'll show you what, sorry, yeah. So this is the FES induced EMG that we collected for various cycles. And then we showed the performance of the a neural network, that how it is predicting. So if you see, what we could do is, if you just read this line where my cursor is, for an input window of 600 time steps and a forecasting horizon of 60 time steps, pre-trained neural network performed the error of nearly 11%, which may look a little higher as of now, but it's a very preliminary studies. I think we have included only 8 or 10 patients. So, but the important thing is in the first line, from the 600 time steps, which means nearly 2 or 3 cycles, we could predict the next cycle. So idea is you record only 2 cycles. You don't need to record the third cycle. You record the second 2 cycles, give it to the neural network. It will predict that what will be the EMG in the next cycle. And because the third one is now predicted, you can include in the first 2 plus the third predicted and predict the fourth, then predict the fifth. So that way you can predict any cycle which you want to predict. So our hypothesis is that neural network will be able to capture the mathematical model of the biophysics of the fatigue. Means what is the biophysics of the fatigue? We don't know. At least mathematically, it's very difficult to derive it. But by giving so many examples of fatigue from various patients, we are expecting that the AI will learn that how this muscle fatigue actually happens, and to model the biophysics of that through the neural network. And it seems that the accuracy of 11% shows that actually it was able to learn that. So this was the work that we did on the stroke patient. And then in the SCI, we are doing kind of a similar thing. However, here the approach is little difficult. So here, again, the challenge here is while giving the, the electrical stimulation, the challenge for a clinician is the model information is not known. We don't know how much of fatigue, how much of the fat, what is the injury level. A lot many variables are there in the model, so it's very difficult to do that. And response of muscle against the fatigue is very non-linear. You cannot decide, there is no mathematical function or there is no linear function which can say that if this much is the FES, this will be the fatigue. So it's a very non-linear, and the model parameters are subject dependent. So each patient will get a new model, which is very difficult to do. So what we did is we tried to develop, this is a spinal cord injury patient at AIIMS. This is the FES unit, and you can see the algorithm is written here. This is a load cell, and here is the encoder. Here is the chair, which is a customized chair that we developed at IIT, and this is a stabilization belt for the patient. Now we are providing the current to these electrodes, and we are expecting the knee angle to move with certain flexion or extension based on the current that we are providing here. Now the challenge is, I don't want to mathematically develop a model here. I want the patient to be here at the place of the model. And let's say the clinician decide, I want to go for 10 degree. So what should be the amount of current to provide here in order to get it 10 degree? So there is no linear mapping, means you cannot decide it. So what we do is we developed an algorithm, something like that. So it's a complicated mathematics, which I will not discuss because that will just be out of the scope for the audience. So In simple use, imagine that we develop a mathematical model, which we are calling the neuroprosthesis. And we are giving certain current and we are getting certain angle to this. Because the model is not perfect mathematically, so this angle will not reach to the correct value. What we are doing is we are taking this angle value back and telling that this is the error from the required value. And then developing a controller which decides what should be the new current to reach to that angle. So this is the performance criteria or performance evaluation of this. And the same thing, what we are doing is by utilizing the multiple models. So it is just the mathematics. I'll show you the video how it works in the real time. This is the algorithms that we have written in the MATLAB for electrical stimulation. This is the controller. You can see here, this is the controller board. This is where the stimulation goes to the nerves. This is the emergency switch in case patient feels uncomfortable. These are the electrodes you can see here. This is the load cell which measures the force, how much force is doing, and here is the encoder. So you can see when I provide the current here, you can see the bulge of the current coming here. The patient is able to move the leg. So if you see, the patient was able to control, I mean, not the patient exactly, but the FES was able to control the angles at different degree. Like, for example, if you see, initially, so for example, if you see here, it is just 10-15 degrees. Then we further increase the current and it reaches to a little larger angle. And finally, he could, extend his entire knee up to the level where it is the maximum. So if I go back to this curve, yeah, you can see here, the knee angle is the blue one, the desired knee angle. And you can see the FES was able to reach, although it took a little bit more time, which is due to the electromechanical delay of the muscles as well as the system. So, but it finally could reach to the desired value of 40 degree in all the patients and in all the cases. So these are the other things related to occupational therapy, which we have developed in our lab. But unfortunately, due to the time limits that has been given to me, I won't be able to put a lot of details on that. But I just thought to disclose what we are doing in our lab. So with this, I acknowledge all the funding that has come from DST, DBT, ICMR. And I also thank AIMS to give us the patient access and all the facilities. And I also thank all the participants from stroke and spinal cord injury to help us with the data collection. These are the fundings that we have got. So we have nearly this much funding, and this is my team. So I acknowledge all my team members for that. So thank you, everyone, and I look forward for the discussion in the panel discussions. Thank you.
Day. Thank you for all organizer of the conference. I hope next time to be with you face to face. My topic today is about assistive technology bridging the gap. I have to start quickly because I have many slides and very limited time. Let's start with the assistive technology definition. The assistive technology, it's a big umbrella, and under this umbrella, we have so many softwares and hardware devices. And the assistive product, it is any product we are giving to patient to maintain or to improve individual functioning and independency. And the demand of the assistive technology, it is high, and the WHO, they are expecting more in the future because the improving of the health system, we will have more aging global population increase in the future. AT product, we have two type of AT product. We have the software AT product, like communication apps, and we have the hardware. The hardware is divided to three groups. We have the high tech, like wheelchair, eye gaze, iPad, phone, and we have the mid tech. Mid tech, it is the devices using the battery and simple programs. And we have also the low tech. The low tech, it's the simple one. It's not using any type of power supply. Rehabilitation assistive technology service, it has four category service. We have the communication sector, and this communication using AAC, the alternative and augmentative communication, for the patient with the communication difficulty like autism, patient with after stroke. And in this section we have so many solutions for communication, from the high-tech solution like using the iPad with the high-tech programs, communication program, and we have the low-tech solution like communication board. About the accessibility, it's about mobile access, we have the tablet access and computer access. We have also using different type of product like mouses, switches, special kind of keyboards with different size, with different colors. And the next one, it is about environmental control. And environmental control is very common now, but we need the assistive technology specialist to adapt, sometime to adapt this device to be accessible for certain patient. The last one, it's about low assistive technology. And later in this presentation, I will discuss some of the low cost assistive device and low tech assistive device, and how function. For moving to the low tech assistive device, I would like to share with you two success stories from high tech device. I have this patient, she has ALS and she has communication difficulty, and she's totally assisted. The AT solution for her, it was to provide her eye gaze system, and the eye gaze system is a system using for multifunction. Its device can capture the eye movement, and after we capture, you can control the mouse on the screen, and by controlling this mouse you can access the communication apps, you can access the YouTube, the social media, even the environmental control. Here my patient, she's using the device, she's using the communication app, and she's able to express her pain, to express her needs, to communicate with the family, and she's using the social media. She's reconnect her friend again by WhatsApp and Snapchat. And the strange thing that the family told me about, that the patient, she's telling about her dream. So we decide to put dreams, to express dreams, one of the goal of the assistive technology. Another story, high level spinal cord injury. He has no communication problem. He's totally assisted. There is no movement, no hand movement, nothing at all. So the AT solution for him using the head mouse glass, and this head mouse glass, it is a device connected to the iPad, and it has a switch, so it help him navigate like mouse, like the same the eye gaze, but this is using the head. Here my patient is using his device, as you can see. Now he's sending message to her mother using the WhatsApp saying good morning. The patient is able to do shopping for his family, online shopping. He's ordering the food, and also he's contacting his son school and the teachers. So the assistive technology, as you can see here, it is empower his role as a father again. And there is a plan for him now. We are trying to assist him if he can do his job from home. So it looked like very successful story, and it made big change for this patient and his family. I drew this cartoon years ago, and it's showing OT with the patient. We are doing the same activity since long time. So I like feel frustrated. I was working with the outpatient, and most of the cases we are doing the same activity. So I start thinking what we can do to change our practice. So I start thinking to do the low-tech device. The low-tech device project, has four categories. It has splinting, tools modifications, toy modification, and therapy tools. I know splinting and therapy tool is not part of the assistive technology by definition, but it helped me a lot because this is a different type of splinting, not the standard one. And the therapy tool, it has different story, so I'll share it to you in the next slides. Patient with cerebral palsy, she has difficulty using her hand because she has deformity in her wrist, finger, and the thumb. So we try to analyze the situation and to design and customize splint only for her. As you can see, how is the patient function and using her hand with this new splint. So it's combination between gutter splint, wrist splint, and thumb traction splint. This splint designed for the patient who cannot tolerate the normal splint because of the increase of the spasticity. So we design it by using the sponge ball, and we stick it to the splinting material. So when the patient he has increase of the spasticity, this ball absorb the excessive force. So the patient he can tolerate the splint more than the normal one. Using the splint with the CP patient, with a stroke patient, some cases of the TBI. So it is strategy with splinting with the patient who has spasticity. This splint we have in the market, but because it's very expensive, so we try to copy the same function, but it's not the same design. So this splint used for the patient who has stroke, and we need like to facilitate the movement after stroke, as you can see. Also, we sometimes try to develop the same product. As you can see, this is the simplest release splint. It's made by the assistive technology in QRAI. And as you can see, it's very simple and it's very effective, and it's very low cost device. The same principle with the patient with TBI. He has problem with the release. The only problem is with the thumb. So we try to make this simple traction, and it is cost effective again, splint. This patient with spinal cord injury, he has limitation of supination. So we try to find or to redesign a splint for him to be able to achieve and gain more range. And we are using for as a static progressive splint, and we are using this also for the exercise. Patient with elbow fracture, the patient, he came to us and the doctor prescribed for him elbow splint, and in the market it is very expensive. So we try to find, comparing with the product in the market, to find a low cost solution for him. We made this without any metals, without any joints. It's only splinting material. So it was very effective for him and it's very simple to use. We will try to generalize the same idea, but in different part of the body. So we try use it with the wrist. As you can see, it's very simple design and it is very effective as a progressive static splint. About the tools modification, starting with the self-care modification, like nail cutter. This the first one. It is using for the stroke patient. I know we have the same product in the market, but as you know, one size is not fitting all. The second one and the third one, it is using for the patient who has incoordination, like old age. So we ask the patient to bring his tool and we make the modification with the same tool he's using. So because of this, this project is cost effective. Eating tool modification. So we try to assess the patient level of function and we try to create for him according to his need and function the eating tools. As you can see, sometimes it's long, sometimes we make the hand big, we change the angle. Here one example of a patient with stroke, left side stroke, and he has old injury in his right elbow, and patient he's going to discharge in, he has in family member in Qatar. So to make the eating easy for him and to be independent in this activity, so we try to create for him long hand spoon and long hand for the cup, and it was very useful for him. Patient with MS, patient he's programmer and he has difficulty using his mouse. So we provide him first the joystick mouse, but he don't like it, so he prefer his mouse. So we try to find very simple solution. Sometimes the solution it is very simple, just only small part of the splinting material to split his finger, and so he can use it without any problem. The next one, it is about spinal cord injury. When they are admitted in the hospital, they have a problem with nursing calling bill, and as you know, in rehabilitation the coverage we haven't one-to-one, so it is part of the patient safety to be able to access the nursing bill. So we try to make this modification. Patient with hand problem, she's old age patient, she has problem with to call the family member she's going to discharge. So we try to find her solution, low cost solution. We ask the family to buy a house bill, normal bill, and we try to make it accessible for her. As you can see, we're using this material for, it is recycling from the switches, because the switches it has extra parts, so we try to do recycling for available material. If we have in this material, we can use different type of material. Mobile access is very important for our patient. So most of the patient, they try after the injury to access their mobile. So we try our best to make this happen for them. Sometimes we try to make splint to isolate one finger to be accessible for them. This is also for patient with the CP, just only small piece of foam. So the patient is able to access the tablet. Here for the PC access, the patient, he has a problem targeting the key, so we made for him very small like pointer. It's made from the water bottle cap and wire. It's very simple and very effective for him. Again, patient with keyboard access problem. So this we made this for the patient who has high level spinal cord injury. This is the patient with high level spinal cord injury. He's working as a technician, and we advise him to change his job to the office job. And after we provide him this technology, the patient became motivated. So he continued his study, and now he's working at the same company, but with office job. Bilateral amputation. Patient, she has difficulty in everything. So in the assistive technology, we provide her everything. We started with her with the mobile access as she's preferred, and then we give her this writing tool because she's still working from home and she need like to sign a paper, and then we make the computer access for her easy because before her husband he is helping her. Now she's independent using the computer and do her job.
Jump.
S with S.
Jumps
Jumps.
over the
Lazy dog.
For eating, we made for her spoon and fork holder, brushing teeth device, and finally hairbrush.
You see, my hands is still flexible. No?
Patient with congenital disease, patient, she's totally assisted. So we create this simple modification and we put the joystick near her feet, and she was able to drive her wheelchair independently. So she's now 14 years old. She's never ever has this feeling that she has the control to move her wheelchair. So it is very inspiring story, as you can see. This simple modification tool for the patient with the CP, and we enable them to handle the colors and the pencils. Patient with TBI, we made some combination between the splinting and adaptation to make the patient write again after 3 years of the injury. We start again to teach him how to use the pencil. Patient with TBI, patient he has no movement in his right hand and he has a lot of spasticity at that time. So we did for him splinting program for 6 months to use his hand, and this is after training more than 1 year training. He was able to write again, and now he's in the university again after he left it for 2 years. Stroke patient, his difficulty to sign his paper because he's businessman, and after stroke he has difficulty. So we design this tool for him to be able to manage his work. So he was very satisfied and was very happy about this achievement. With a spinal cord injury, the patient at that time he was 17 years old and he has difficulty to go back to his school. So we help him to go back to his school and to use the pen. And he's finished high school. And when I contact him last week that I want to present your success story. He sent me this picture saying that this is too late, Salah, because already I presented my success story in my university. So you can see the change that we can do for our patient to engage them again in their school and in their work. Sometimes the modification is very simple, like cup holder and mobile pocket. Usually I'm using this printing material, but now I'm challenging myself to do it with very cheap material, because you know this printing material, it's expensive. So we try to make modification for spinal cord injury mouse. As you can see, it's very cheap and very accessible. Now we have the toy modification. Toy modification is very important, I think, because the patient, when he see the other kids, they are playing with the toys. So we try to make modification to make it more accessible for the patient. As you see, we put switch and we make some steering modification to make it more accessible for him. Toy modification again, joystick modification. It's very simple, cost effective. The last part, it's about therapy tools. And this therapy tool, it's a new idea. As you know, not all patients they can come to the therapy, so I've tried to create for them exercise tool so they can do the exercise at home. You can educate patient and you can take the tool and to do the exercise at home. This is biofeedback and give the patient the feeling of movement and the repetition. So based on the repetition, the patient he's using this tool and it's safe, and we educate them to do it without pain, without fatigue, and it's very effective. You can use it for the upper extremity.
How old are you? 8, your age. What's your age? Years, how many years are you? How many years are you?
Also, you can use it for the lower extremity. For orthopedic cases, like strengthening, improving range of motion. So it looks like universal tool. It gives feedback of movement, so the patient keep doing the repetition. So this tool encourage the patient to do repetition again and again. We try to make it little complex, so we add vibration motor to this tool. It is still low cost. It's less than $2 cost of this tool. You can use it for different part of body to exercise the the arm, and you can use it also for lower extremity. Now we are conducting this research for this tool to find evidence about the use of this device, and I think it help a lot the patient who cannot afford therapy or who cannot come for the therapy, and you can monitor this tool online. Last device, this one, it's still under development and under study. So this device, we try to find more biofeedback for the patient, so the vibration, and we add a light here. And actually, I'm using the toys recycling to make this tools. Finally, thank you for listening. Thank you very much. Good morning. Thank you for having me today.
Okay, okay. So this question is for me. Okay. Okay, okay. I did it. Okay. This is for me. Hello. No, I'm not able to hear anything. Can you hear me?
This thing that listen. As if we have. So I'm for. So sound the check. So it's up to us to decide what to use and what not to use based on science and some kind of. So scope of practice of the facility is a document, written document, which will tell you what to do, what not to do. There is job descriptions of a therapist who has to work in a facility. There is operational governance where what PT has to do, what OT has to do. Just so if you are clear of taking out this infighting between professions, practicing interdisciplinary practice where we have a common goal, which is to make the patient better as much as possible. Then we drop out all the conflicts. We look at the science. Who's competent to do it is doing it, and our profession supports it. We have a lot of our syllabus, the way we study supports what we are doing as practice. So we don't need to There are people who don't study something, but they're still practicing it because of competence. But we still have a base for syllabus, which supports us, and then we have competence, which makes us more better professionals. So if somebody is working in neuro rehab, probably this will be an interesting way of looking at it. I don't know whether I've answered this question, but I'm trying to, because these kind of questions come from senior people who for sure have not completely accepted technology as an addendum to rehab. But I would suggest you with humble request, please visit facilities where we have technology working. Come and spend with us a week or something like that so that you will understand it fully. So you understand that there are two spectrums, high cost technology, low cost technology, and we take wherever we want to take what we want to take, and we know the principle behind it. Thank you so much.
Thank you, Dr. Premraj. You ready? Dr. Nekram, sir, can you hear us?
Yes, I can hear you very well.
Just elaborate about steps involved in setting up a AT center at any hospital or institution.
So this is specific to some health condition, or is in general you would like to answer? Answer. Yeah. Can you hear me, Dr. Neeraj?
We can hear you.
So this is it's a good question, but then this is to something to do with the specific health condition, or in general you would like me to answer?
In general, sir.
Okay. So actually that's the challenge that we have in our country. We don't have a standard procedures at this point in time, but of course, eventually it's coming up in near future that we'll have some standard guidelines. But I can share the experience that we carry on, and I'm sure the people from Qatar, they also maybe comment on this. So of course, any hospital or a rehab center or a small clinic, those have been running for serving people with different kind of health conditions, be as a maybe pediatric, adult or elderly, having different kind of disability. Though, of course, the assistive devices and technology procedures and product itself, they cater to different needs of the people. So it's related to mobility, communication, and then of course for visually impaired, there's different technology. For hearing issues, there are different technologies. Then the people with cognitive issues, pediatric having the communication issues. So the different technologies. But what I would like to say that, of course, first of all, you have to have the concept of delivering assistive devices. That is something totally different than the clinical practice. So you have to have the people who understand the products, the range of product for particular solutions. So we mainly focus on the impairment rather than the health condition. So if you look at the impairment and then the limitation and challenges to interact or to perform the activity. So if you take an example for maybe just a stroke, right? If they have limited hand functions and they would like to maybe, have, a pills by themselves, then what kind of assistive aids or orientation of keeping the pills, opening the container, taking it by itself? So what sort of technological surroundings would we customize? So that is the person who is serving, they need to understand this. So that means you have to have personnel who are trained in assistive devices, finding out technical solutions, customization, the fabrication lab. Of course, you have to have a little workshop where you can fabricate the tools in real times. And then every person has to be thoroughly assessed for the need. So there has to be a person who can assess thoroughly. There's some little bit technical person who could maybe sometimes the OT does a lot of work, in terms of fabrication. So you may require some technical assistance, maybe some engineer or technical person who can work on your directions. So better to have some person like this in the clinic, a little workshop, then of course the assessment protocols, customization, but I will always prefer to have the person in the clinic. So real-time assessment, real-time fitment, you might have to go back and forth number of times, customize the products. So that particular scenario has to be built up in under one roof. Assistive technology does not mean that somebody is coming to you for assessment and you just recommending something that, okay, now you need this product with these features and now this up to you to buy from somewhere else, or you're recommending somewhere, some supplier or some. So they're directly dealing with the supplier, or they're buying online or something. That might not fit the person, right? Fit to the person. So the assistive devices has to be delivered, the training has to be given, then all the needs to be matched, or we need to basically focus on performing their activity with the assistive devices. So
All right.
assistive technology center means there's a particular place where the person can visit. So do the assessment, there are devices there, products there, somebody there to doing assessment and real-time modification and giving training and delivery, and also doing follow-up. So people can come and, again, revisit to, sorry.
All right. Thank you, sir. Next question is for Dr. Deepak. Sir, how can you elaborate how difficult it is to implement adaptive FES in the real time? What challenges do you face?
So it's quite challenging. Let me be very honest. I mean, the reason is that every patient is different. Like Dr. Nekram just said, the personalized kind of thing. Every individual is different after the injury. So you cannot apply the same doses of electrical stimulation to other patient and expect the same recovery. So adaptive FES in that way is quite challenging, and probably what probably would be the necessary step to go ahead with is like you have to tune your algorithm a little bit here and there. Always you are on that sweet spot, but for a particular new individual, you might have to just tune your parameters of FES, which are generally either the frequency of the current or the amplitude of the current or the pulse width of the current. So other than that, I mean, this is at the clinical setting, but when we do in the research, we have liberty to explore various algorithms to make sure that it is model independent. When I say model independent, it means that even if the new subject comes, my algorithm automatically adapt to the new patient. So technically speaking, it is challenging, but there are solutions for that. So it's bit of engineering component dominated, but there are solutions for making adaptive FES.
Thank you so much, sir. We have limited time left with us. So with this, we come to an end of the panel discussion. Thank you so much, all faculty members, for sparing time from your busy schedule and joining us. And sincere apologies to all of you for the technical glitches in between. However, we could complete it. That's a good thing. And thanks to all participants for bearing with us. Thank you so much.
Thank you. Thank you very much.
Thank you, everyone.
Thank you. Thank you, Dr. Premaraj. Thank you, Dr. Neeraj Mishra and all others. I would request our senior most occupational therapist, Madam Bole. She's here with us. So I'll be very happy if you can come up and felicitate our speakers. Madam Bole, please. Was this good? Yes, Dr. Premaraj. You're lucky to be felicitated by such a senior OT. And she was once upon a time even academic council as a EC member. I'll call upon Neeraj Mishra. You did a wonderful job, Neeraj. And always, I know he will never make a single mistake. He's perfect. Thanks a lot, Neeraj. Thank you. Also, I would thank all my ACOT ECs, Dr. Zareen Fazandi, Dr. Shailaja Jaivan, Dr. Kamal Arya, and Dr. Vijay Batra to help me in organizing without any mistake, with zero mistake. They have organized this COTE program. Thanks a lot, my dear executive committee members, and thanks to all the scientific committee people and the organizers to have this place for us. Thanks a lot.